Hello guys, how are you all? How are you all? Islam, hi, gorgeous girl, good evening. Atif Anwar, hi Anwar. Moisbin, hi Moisbin. Kanish, hi Kanish. Gopala, hello. So I'm really happy that I'm meeting all of you after a long time, right? So I think there are a lot of students here from ISM, right? The Central Campus, Kokshito, Asian, Caspian, some from different universities, right? In some of the universities I've taught micro and some of them haven't attended my anatomy classes. So thank you, Sanyasi. Thank you. You're back finally, Sanyasi Pandit. Akshay, good evening, Akshay. Raviteja, hi. Abdullah, hi, Abdullah. Karma, the gaming, you are back again. Very nice to meet you all. Surgery, hello. Good morning from Washington. Rini Atkinson, good morning, good morning. Nagendra, good evening, Nagendra. Anjali, this side, hi, Anjali. Ananya, hello. Right. So, guys, actually, we are about to start the anatomy rapid revision. Okay, so in this rapid revision, one very important thing I want to tell you is that this is the rapid revision, so we cannot cover all the topics as we usually cover in our regular day-to-day classes as well as our recordings. So if you want a detailed video lectures, they will be in the app, and our app is going to be released soon. Okay, so all the details will be mentioned in the Telegram page. And second important thing is that regarding this rapid session, I will be discussing the most important topics which were previously asked and the most anticipated topics which will be definitely asked in the exams from each system. Okay, so let's not waste the time, and let's start discussing all the topics now. Thank you so much, Nasir. Felicia, good evening, Felicia. Sudhansh, thank you, Sudhansh. Even I am excited. Right, so all of you look at the screen now. So these are the topics which you see in case of upper limb. Upper limb. So these are some of the important topics which we are about to discuss today in the upper limb, right? And one small request I want from all of you is that through this entire session, I want you to be fully energetic and make me also fully energetic to teach you. Okay, right? So the first topic which we shall be discussing is the clavicle. But before that, okay, we shall discuss one very important thing. One very important thing is that all of you know, first of all, we shall know when does this upper limb start development and when does the lower limb development start and all. Okay, now as you can see in this picture over here, this is your neural tube. Okay, now all of you, yes Aki, we shall be discussing all the things. Okay, all the things, even thorax also we shall discuss today. Now all of you know the germ layers. We have got ectoderm, we have got mesoderm, as well as we have got endoderm, है ना? अभी ये देखो, ये outer layer जो है, this layer is called as ectoderm. This layer is called as ectoderm. And this middle layer, whatever you can see here, middle layer, this middle layer is called as mesoderm. Okay, ectoderm as well as mesoderm. No, Dharan, we shall complete all the anatomy today. And the innermost layer is called as endoderm. This thing all of you know, right? Now my main focus is about the mesoderm itself. Now if you can see the mesoderm, let me draw one straight line. Okay, this straight line whatever I'm drawing is called as the axial line. Axial line ke side jitne bhi hai, they are called paraaxial. All of you know that. So it means surrounding to the axis, this part is called as paraaxis. So what should I call it as? I should call it as paraaxial mesoderm. Paraaxial mesoderm. And things which are completely away from the center, right? Things which are completely extreme to the center, they are called as lateral part. So this part is called as the lateral mesoderm. Okay. So here we have got two types of mesoderm so far we discussed. One is called as paraaxial mesoderm and the other one is called as lateral plate mesoderm. Nagesh, good evening, Nagesh. Lateral plate mesoderm. अब paraxial और lateral plate mesoderm के बीच में in the center whatever is there, that is called intermediate, है ना? So this one which you can see over here, this one is called as intermediate mesoderm. Okay, so this one is called as intermediate mesoderm. So how many types of mesoderm we have got, guys? We have got paraxial. I'll let you know why am I telling you this. This is very important. We have got paraxial mesoderm, we have got lateral plate mesoderm, and we have got intermediate mesoderm. Now, from paraxial mesoderm, what will develop? From intermediate mesoderm, what will develop? And from lateral plate mesoderm, what will develop? We shall discuss now. Okay? अब ये देखो, this point which I'm going to tell you is very, very, very important. From the paraxial mesoderm, what will develop, guys? Any idea? Anyone? Now, those who attended my classes should not answer because you already know. Those who haven't attended, only they have to answer now. Any idea that very good, Aki, very good. Paraxial mesoderm develops into skeletal muscles. It will develops into skeletal muscles. Whereas the lateral plate mesoderm develops into upper limb as well as lower limb. So upper limb and lower limb development, both of them starts from the lateral plate mesoderm. In the same way, intermediate mesoderm develops into your genitourinary system. Genitourinary system. So this box, even if you want to remember this picture, that is well and good. Even if you don't remember, but for me, please remember this box. This is very, very, very important, guys. Okay. Now, if we look at Sufza, very good, Sufza Abdullah, very good. If we look at the development here, right? When does the upper limb start developing? The upper limb starts developing by the end of 4th week. End of 4th week. But whereas the lower limb starts developing by the beginning of 5th week. Beginning of 5th week. Right. So end of 4th week. Very good, Kundu. Varshita, very good. End of 4th week and beginning of 5th week. Very good. So guys, till here, whatever we discussed, we came across 2 MCQs here. Right, so this is box number 1 and this is box number 2. You understood these two before I move on to the next one? Yes or no? Everyone, guy? Yeah, message fast because we have a lot to discuss. That's why message fast. Very good, Sufza, very good. Now, all of you, just let us do 2 questions, guys. 2 questions and then we shall move. Okay. Ye dekho. The questions which will be asked from this embryological point of view in upper limb, whatever I've told you just now, okay? Lateral plate mesoderm and paraxial mesoderm are the derivatives of. Who will tell me? Who will tell me this answer? Just now I told you lateral plate mesoderm and paraxial mesoderm. So what will be the option? Just tell me the option. So you're telling D. Very good. Lateral plate mesoderm develops into upper limb and paraxial mesoderm develops into skeletal muscle. Very good. Now all of you look at the true or false statements here. Development of upper limb starts at the end of 3 weeks. Yes or no? This is false. Very good. This is false. Development of upper limb starts at the end of 4th week. Yes, this is true. And development of upper limb starts by the end of 5th week. No, it starts in the beginning of 5th week. So E is also true. Remaining all are false. Right? Remaining all are false. Very good. So I hope you understood that option B and option E, both of them are true. Very good. Divya Trivedi, very good. Option B and E. Raviteja, D nahi. D is end, not end. Okay. It is beginning. Okay. I hope you're a little bit confused, but I know that you know the concept. Right. So after this, as we discuss, the first topic we shall be discussing is the clavicle. Let us see what are the questions that can be asked from the clavicle. Okay. So all of you also along with me put down the heading clavicle, guys. So all of you know this is clavicle, right? Now in this clavicle, the first important point which you need to know is that when does clavicle development start? So clavicle development starts during the 5th to 6th week of intrauterine life. IUL matlab intrauterine life. And during the intrauterine life, clavicle is the first bone to ossify. There is no other bone. Okay. So the first bone to ossify during intrauterine life. First bone to ossify during the intrauterine life is your clavicle. Okay. And second important thing, all of you know, right? Never mind, definitely it is useful. Definitely, just trust me, definitely it is useful. And I'll also tell you why it is useful at the end, okay? Right. Vanilla, I'm good. How are you, Vanilla? Right. So, second point, this is the most commonly fractured bone in the body. This is the most common bone which is fractured in the body, right? And third important point is that, can anyone tell where is the site of fracture, guys? Where do you see the fracture? Yeah, where do you see the fracture? Okay, I'll tell you one statement. Is it right or wrong? The fracture fragment is seen. The fracture fragment is seen in the medial 2/3 and lateral 1/3. The junction between medial 2/3 and lateral 1/3. Is it right? All the students who attended my classes, they might have known this. No, no. Some of you are right. See, there is a new update, guys. The new update is that the fracture happens in the junction between medial 3/5 and lateral 2/5. Okay, so all of you note down this point. Whoever don't know, just note down this point, that the junction between the medial 3/5 and the lateral 2/5, this is the place where the fracture most commonly happens, right? So is this thing clear, all of you? Is this thing clear to all of you? Yeah, very good. Now let us proceed further. So whatever we discussed, this is the during 5th 6th week of intrauterine life, this will start ossifying. This is the first bone to ossify, most common fractured bone, and medial 3/5 and lateral 2/5, the junction between that is the fracture site, right? Now all of you just look at this picture. In this picture, what you can find, guys? You can find this thing called as your clavicle, है ना? Clavicle के बाद this part which you can see here is your coracoid process. Coracoid process. Okay. Now, if I'm drawing a ligament between clavicle as well as coracoid process, what will be the name of the ligament? Anyone? Ali Javed? Yes. But if you be in the live session, the advantage is that even if you ask any question, so that I could answer it. Okay. So this ligament is called as coracoclavicular ligament. Coracoclavicular ligament. And you know one thing, that coracoclavicular ligament is the strongest ligament of your upper limb. So this is one more MCQ, that which is the strongest ligament of upper limb, strongest ligament of upper limb, that is your coracoclavicular ligament. Very good. Very good, Samu. Kazumanana Samu, very good. Very good. Shivanshu Kumar Pandey, very good, Shivanshu. All medical lectures, very good. Right, gangster, I'll show you the image. Okay, where is the exact site of fracture? I'll put an X-ray and I will show it to you. Okay, right. And next important thing is that, guys, there is one clinical point which I want to tell you regarding the clavicle, that there is an autosomal dominant condition. Okay, in this autosomal dominant condition, sometimes one clavicle or almost both of the clavicles, they are absent, they don't develop. Underdeveloped clavicles is called as a hypoplasia of clavicles, right? So such condition where both the clavicles are underdeveloped or not at all developed or absent, this condition is called as cleidocranial dysostosis. Okay? Agar clavicles nahi hai, then what will happen? Do you think my shoulders are apart like this? The shoulders are wide apart? No, both the shoulder tips touch each other. Okay, so all of you look at this condition. You see both the shoulder tips are touching each other. Why? क्योंकि यहाँ पे clavicle नहीं है. There is no clavicle, and this condition is called as cleidocranial dysostosis. Cleidocranial dysostosis. And what is this? This condition is an autosomal dominant condition. Autosomal dominant condition. Okay. Now in this, what is happening? There is underdeveloped or hypoplastic clavicles. Hypoplastic clavicles. This is one very important clinical point, guys. Akhil, yes, I speak Telugu. Yeah. Very good. Vikash Raj answered correctly. Very good. Abdullah, Himanshu Giri. Very good. Perfect, guys. I want you to learn the entire anatomy clinically like this. Very good. DDD, RRR, you can get a PDF immediately after the class. Okay? So, shall we continue now? We shall continue. Now, one important thing you need to know is that, sir, agar clavicles absent, then why both the tips of the shoulders are touching each other? Because the pectoralis major muscle, whatever is there, is pulling this right shoulder like this, left shoulder like this. So both the shoulders, they touch each other because of the contraction of pectoralis major, right? If you want to know it, or else it is not that important. Right. So someone asked me, show me the exact point where the clavicular fracture has happened. Can all of you see the fracture side here, guys? From the medial end till here, this will be the 3/5. That is what I call medial 3/5. Or lateral, lateral kitna hai? 2/5 hai. So this is the fracture site of clavicle. Is it clear? Dharan side, definitely it will help. Definitely, because I used to teach croak from many years and I know what are the things I have to put it here. Okay. So I hope you understood this. Right. Now, after the clavicle, the next important bone we shall be discussing is the scapula. Okay. Now, in the clavicle, what did we discuss? We discussed 4 or 5 important points along with the fracture. Okay? In the scapula, there is only one important thing which you need to know. What is that one important thing is that, see, during the development of the baby, what will happen is that the scapula are present in the cervical region. Okay? So, from the cervical region, for example, if this is the scapula is present in the cervical. From the cervical, the scapula will descend down into the thoracic region. Okay? So, at which week will the scapula descend from the cervical region to the thoracic region? It will descend down during 9 to 12 weeks of gestation. Okay. So during 9 to 12 weeks, the scapula will descend down. During 9 to 12 weeks, the scapula from the cervical region, it will descend down into the thoracic region. On the back, posteriorly. मान लो ये, for example, out of 2 scapula, because of some kind of cervical abnormality, ठीक है? Because of some kind of cervical abnormality, out of 2 scapula, one descended down and one is in the neck itself. Now, when one is in the neck itself, this condition, if you look at the patient, you will see that one neck, right? One neck is up and one neck is down. I hope all of you have watched Pushpa movie, right? So in Pushpa, you see one neck is up, one neck is down, right? I don't know whether he had this abnormality or not, but this is how the abnormality looks. Why? Because one scapula is on the top in the cervical region and one is under the normal position. This condition, you call this condition as Sprengel deformity. Okay? Very good. Shruti already started answering. Very good. You see this condition here? Dekho, one scapula is on the top, one scapula is under the normal position. This is a normal. And this is D for deformity. Very good. This deformity is called as Sprengel deformity. Sprengel deformity. Why? What is the cause of Sprengel deformity? Because of cervical spine abnormality. Cervical spine abnormality causes Sprengel deformity. Right? Very good, Yogesh. That is Kippel-Phil syndrome only. Let us not go into that details here. Blessings, Wamba blessings from Zambia. Love you too. Right. So, all of you just do this question, guys. Let us see. Will you be able to do the clinical question here? 5-year-old patient presents to the orthopedic clinic with shoulder asymmetry, okay, and limited abduction. The patient's parent explained this deformity has been present since birth, okay. And now the child is unable to reach overhead and participate in a play. On examination, the left scapula is elevated. ये देखो, left scapula elevated है, right? Which of the following is the most common associated finding? So left scapula is elevated, matlab this is the picture. So the answer will be what? Cervical spine abnormality. Cervical spine abnormality, right? Next, which of the following condition is characterized by failure of scapula to migrate caudally? What will be the condition? Yes, anyone? What will be the answer? Very good, Amna. All of you answer right, but answer this one. Sprengle. Abdullah talks, Dharan Sai, perfect. This is sprengle deformity. Very good. Divya Trivedi, Varshita, Komaldeep Kaur, very good. So, next important thing, look at this question. 8-year-old boy presents with extreme shoulder motion. See, the shoulder is extremely motile, right? Extreme motion. It is under extreme motion. And frontal blousing. A chest radiograph is shown. So what is your diagnosis? ये है chest radiograph. इसमें क्या दिक्कत है? What is the problem here? ठीक है, ये बताओ. What is the problem here? If this is an X-ray, what is the problem? Be fast, super fast. नहीं, what is the problem in this X-ray? Yeah? Varshita Ji, cleidocranial dysostosis, no. This is a normal X-ray. Very good, Vinay Sai Verma, this is a normal X-ray. You see a clavicle here, you see a clavicle here. Just compare this X-ray with this X-ray. Do you find any clavicle over here? No clavicles on either side, right? So this condition you call it as cleidocranial dysplasia. Cleidocranial dysplasia. Clear? Very good. So after yeah, sorry Varshita, you are about to tell the top one, right? Very good. After clavicle and scapula, the next important topic we shall be discussing is your humerus. And I'm telling you guys, from this humerus, every year one question is asked, right? It all depends upon how well you listen to the class here. So all of you just pay attention to whatever I'm doing here. So this is your humerus, right? Wherever the head is there, that is the medial side. Okay, humerus, and here you have got your radius and ulna. And one very important thing I want to keep you in mind is that this one is called as medial epicondyle. Okay, this is called as medial epicondyle, or ye jo hai na, this is called as lateral epicondyle. Medial epicondyle as well as lateral epicondyle. Now stop commenting, guys. Just look whatever I'm teaching. Now, if you look at the humerus, this part which you can see, this is called as the surgical neck of the humerus. Okay, so matlab ye, this is called surgical neck. Now, near the surgical neck, right, we have got a nerve. This nerve is called as axillary nerve. Axillary nerve, where it is? Near the surgical neck. Surgical neck. It means, for example, if I tell, agar patient ko surgical neck fracture hua, then which nerve will be injured? They will ask in the exam. What will you tell? You should tell it as axillary nerve is fractured in surgical neck fracture. Okay, axillary nerve is damaged in surgical neck fracture. Now, when you come little bit down, this is the anterior side. I am talking about the posterior side, back. On the back side, you have got a small groove. That groove you call it as radial groove. Okay, ye dekho, on the back side, you have got a small groove posteriorly. And that is the reason why I'm drawing it with the dotted line here. Okay, so this groove is called as radial groove or spiral groove. Now within this, there is a nerve that is called as radial nerve. Radial nerve. Where it is located? In the spiral groove. Spiral groove or radial groove. And where is this spiral groove? Where is this spiral groove located? It is located in the mid shaft of the humerus. Agar yahan pe mid shaft fracture hua, then which nerve will be damaged, guys? Radial nerve will be damaged. Okay, if there is a mid shaft fracture, then radial nerve will be damaged. And where is the spiral groove? It is not anterior. Again, I'm telling, it is posterior to the humerus. Posterior to the humerus. Okay. Now, next important thing is that if you come little bit down, all of you just focus on the image which I'm drawing. You see a red color nerve that is coming down, and it is passing behind the medial epicondyle. A nerve which passes behind the medial epicondyle is your ulnar nerve. Okay, Behind the medial epicondyle, this is your ulnar nerve. Very good, Abdullah. You see, this is your medial epicondyle. So if medial epicondyle fracture will happen, which nerve will be damaged? Ulnar nerve will be damaged. Okay. Next important thing is that you can see this is medial epicondyle, this is lateral epicondyle. दोनों epicondyles के ऊपर, this area is called as supracondylar region, above the epicondyles, right? This supracondylar region, in this supracondylar region, you will see a nerve that is coming down, at the same time an artery also that is coming down. So exactly at this region, guys. Okay, the nerve and the artery, let me write it down here. So in the supracondylar region, people already started answering. I'm really happy that you are perfect with all these things, guys. Really happy. Supracondylar region. So if there is a supracondylar fracture, then which nerve will be injured? Median nerve. Median nerve will be injured. Along with that, brachial artery also. Brachial artery also. Right? Brachial artery also. So these are some of the most important and high yield topics which you need to know in the humerus, guys. So once again, guys, let us make a quick review here. Surgical neck fracture, axillary nerve. Okay? Axillary nerve. Uske baad, medial epicondyle fracture, ulnar nerve. Okay? Next, midshaft fracture here, because there is a nerve passing posteriorly. So midshaft fracture will lead to injury to the radial nerve. And in the same way, supracondylar fracture will lead to injury of median nerve as well as brachial artery. Okay. One extra point I want you to remember here. One extra point that just now I told in the surgical neck, I just told you, we have got axillary nerve, है ना? We have got axillary nerve. Axillary nerve ke saath saath, there is also two arteries. One is called anterior circumflex humeral artery. Anterior circumflex humeral artery. Uske baad posterior circumflex humeral artery. These are also present in the surgical neck. So they will also get damaged. So all of you understood, guys? All of you understood this. I will make you to practice the x-rays also. You should answer me that time. Okay. So till here, all of you understood? Now, very good, Dharan Sai. Very good. Now, one question that, sir, how all these fractures happen? All these fractures happen because of a type of injury called Fuchs injury. Okay? Fuchs injury matlab fall on outstretched hand. Okay? Fall on outstretched hand is called as your Fuchs injury. Guys, मैं अभी x-rays दिखाऊंगा आप लोगों को. Okay? I'll show you x-rays. You will diagnose and tell me. ठीक है? मान लो कि ये x-rays आपके एग्जाम में आएंगे. They will come in the exam. Just think like that and answer me what is the fracture and what is the nerve injured. ठीक है? So first, x-ray number 1. Which fracture is there here? Okay, don't tell me the fracture. Directly tell me which nerve is injured. Which nerve is injured here, guys? Very good, Abdullah. Abdullah, Salat. Perfect, guys. So here you can see a fracture, all of you. All of you can see a fracture, surgical neck fracture. So this is a surgical neck fracture. Surgical neck fracture. I'm not writing the nerve because you know it. Sudhanshu Pandey, not ulnar. ये ulnar नहीं है. ये देखो ऊपर है ना fracture. Surgical neck fracture. You see the ball has come out. है ना? Very good. अब ये बताओ. Sudhanshu will tell me what is the second x-ray. Sudhanshu, tell me what is the second x-ray here. कौन सा fracture है यहाँ पे Sudhanshu? Be fast. Very good. Kazumanana, very good. This is axillary fracture because of surgical neck fracture here. Axillary nerve has been injured because of surgical neck fracture. Very good. Now let us go on to another x-ray. Before I go to another x-ray, guys, I just want to tell one very important clinical point. Okay? What is that important clinical point is that this is the lower end of the humerus. Okay? यहाँ पे दो nerves है. One is called, one nerve is there and one artery. Median nerve as well as brachial artery. Okay? So let us say patient is having a fracture at this region. Now, after having a fracture at this region, let us say you have visited a local RMP or someone, right? And who is not even skilled enough to put a cast or a slab, okay? But if you are padding all the things, the cotton, the slab, the POP and all these things, if you are padding it so tightly, don't you think यहाँ पे muscles है, there are nerves here, there are arteries like brachial artery, nerve like median nerve, right? And there are also muscles, all of them will be compressed. When all of them will be compressed, do you think will there be further blood supply to your forearm? There will be no blood supply to your forearm, right? Why there is no blood supply? Because there is a problem that happened here that is called as compartment syndrome, right? In compartment syndrome, all the structures of the compartment are compressed. Okay, so because of this, the forearm muscles, they die, right? The forearm muscles get atrophy. Kyun? Kyunki there is no blood supply to the forearm muscles, and that condition you call it as Volkmann's contracture. All of you look at the picture over here. This is the Volkmann's contracture. Amna is already told this is Volkmann's ischemic contracture. Very good, Amna. You see the atrophy of the forearm muscles over here. You see the atrophy here. All these are the atrophy of the forearm muscles. So this is called as Volkmann's ischemic contracture. Ischemic contracture, right? So very good. Okay, so this is most commonly seen in case of supracondylar fracture. Supracondylar fracture. Clear? So till here I hope all of you are clear. One more clinical point is that all of you can see this X-ray over here. In this X-ray, the place where the muscle is present, in that place you see some white color deposition here. ये देखो यहाँ पे भी. This white color deposition is nothing but the calcium getting deposited in the muscle. Okay, if the calcium gets deposited in the muscle, very good guys, you are answering it already. This condition you call it as myositis ossificans. Myositis ossificans. So myositis ossificans is a condition where Amruta, very good, calcium gets deposited within the muscle. Okay, so till here everyone is clear. Give me an okay if you are all clear, guys. Be fast. Very good. Komaldeep Kaur, Sufza, Rockstar. Very good. Now it is time for you to answer. ठीक है? Now you will answer me. Okay, ये बताओ, ये कौन सा fracture है? What is this fracture? Okay, don't tell me what is a fracture. Just tell me what is the nerve that is injured here. What is the nerve that is injured here? Very good, very good, very good. This is the radial nerve that is injured. क्यों? क्योंकि this fracture is a mid shaft fracture. This is a mid shaft fracture of the humerus, and your radial nerve is injured here. Radial nerve is injured here. Very good. Now the next one, okay? The next one, look at the second one here. Tell me, ये कौन सा fracture है? Which nerve will be injured here? बताओ जल्दी. Nerve, very good, very good, very good, very good. Abdullah, not ulnar nerve. You know the answer, Abdullah. This is a supracondylar fracture. Supracondylar fracture. ठीक है? Supracondylar fracture में median nerve और brachial artery. ठीक है? Close. Median nerve और brachial artery. ये देखो, ये भी supracondylar fracture है. This is humerus. This is ulna. This is radius. And this is the supracondylar fracture. है ना? Tell me this one again. This one, let us say number 4, X-ray number 4. Which nerve is injured here? Very good, very good, very good. Not median, not median. Frederick, this is not median. This is midshaft fracture. So this would be your radial nerve. Radial nerve. Okay? Who will tell me this one, guys? Who will tell me this fracture? If you tell me this fracture, I'll agree that you understood all the things so far which I have discussed now. Amna, very good. You see a small part of the bone is broken down. You know? So this is actually the medial epicondyle which is broken down. So ulnar nerve damage. Because of medial epicondyle fracture, it will lead to ulnar nerve injury. So this is all the questions that they can ask you from the humerus, guys, right? These are the maximum questions which they will frame from the humerus, but individually we will talk about nerve injuries now, right? So before that, these two questions are there. I will do these two questions at the end of the upper limb, right? So that I know definitely you will answer them. I don't want to do the questions right now itself, right? Now moving forward, let us see how much you remember. Moving forward, we will discuss about radius as well as ulna. Now, when I will discuss about radius and ulna, guys, when I'm putting my hand in this direction, this bone which you can see is the radius bone. So the same direction I'm putting it here. This is the radius bone which you can see. है Now what I'm doing is that I am causing a fracture of the radius. ये देखो, यहाँ पे एक छोटा सा fracture है, right? So there is a fracture of radius here. So the first thing I should call this as distal radial fracture. है ना? This is a distal radial fracture. ठीक है? इस distal radial fracture में क्या हो रहा है? What is happening here? What is happening is that the distal fragment, whatever is there, this distal fragment is moving upward, right? I can also call it as dorsal angulation of the distal fragment. ठीक है? So from here the fragment is going up. So up in the sense dorsal. So I should call this as dorsal angulation of the fragment. And third important thing is that any fracture that is going up, that is called extension type of injury, क्योंकि यहाँ पे सारे extensors है. Any fracture that is going down, that is called flexion type of injury, because all these are flexors. So now tell me, this is extensor fracture or flexor fracture? This is very good, extensor fracture. And out of all these 3 points, the most important fourth point is this fracture is extra-articular. Okay, this is extra-articular fracture. Clear? Now, all of you look the opposite. Exactly opposite of that fracture is the second one. So, even this is also a distal radial fracture. Distal radius fracture. And this is also extra-articular. Extra-articular के साथ साथ the third important thing is this is a flexor type injury. And anyone tell me if this is a dorsal angulation, तो ये कौन सा angulation होगा? This angulation is called as, very good, this is called as volar angulation. Volar angulation or ventral angulation. ठीक है? Now you know two cricketers, one is Kohli, another one is Smith. So if you compare Kohli and Smith, obviously both are good. If you compare Kohli and Smith, who is on the top? Right now, Kohli is on the top. So compared to Kohli, Smith is in the bottom line. So any fracture, distal radius fracture that is going up is called as Kohli's fracture. Okay, remember like that. That is called as Kohli's fracture. If the distal radius is going down, that is called Smith fracture. Smith fracture. So one is called as Kohli's fracture, another one is called as Smith fracture. Okay. Now you will tell me by looking at an X-ray it is Kohli's or it is Smith. Okay. अब ये बताओ, ये Kohli's है कि Smith है? Tell me. Be fast. Someone telling Smith? Very good beta, shabash. Very good. ये ना normal X-ray है ये. This is normal X-ray, not a fracture. ये देखो ये normal X-ray है. This is the radius. बस करो अब. This is a normal X-ray of the radius. अब देखो. Now look at the fracture here. Can you see a fracture fragment that is displaced upward here? And fracture fragment is displaced upward. This is called as Kohli's fracture. This is called as Kohli's fracture. Okay? This is called as Kohli's fracture. Now, next important thing is that, guys, in Kohli's fracture, This is how the fracture is. ये देखो, this is a fracture fragment. ये fracture fragment ऐसा ऊपर displace हुआ, इसीलिए यहाँ पे swelling है on the top side. But if you exactly compare this one with this, just look here. This is a fracture fragment and these are your fingers. You know, these are your fingers. Isn't it looking like a dinner fork? So Colles fracture is also called as dinner fork deformity. Dinner fork deformity. Okay? Colles fracture is also called as dinner fork deformity. Okay? So you just have to remember 4 points here. Colles fracture is a distal radial fracture, dorsal angulation, extra-articular and dinner fork deformity. When it comes to Smith fracture is also called as garden spade deformity. Garden spade deformity. मैं दिखाऊंगा अभी आप लोगों को garden spade deformity. I'll show it to you now. Okay? Just look at this. Again, in this X-ray also you can see a small fragment that is on the top. Right? Pranam. Praduman, Pranam. Right. Very good. Very good. Very good. So again, this is also an X-ray. This is also a dinner fork deformity. और ये भी dinner fork deformity है. ये भी dinner fork deformity है ना? Now, all of you pay attention to this particular X-ray, guys. Pay attention. You see the distal fragment. Distal fragment is not on the top. It is on the bottom. है ना? It is on the bottom. So if the distal fragment is on the bottom, this fracture should be called as Smith fracture. Smith fracture. All of you can figure out this one, guys. Figure out this fracture. You have figured out the Smith fracture. Will you answer it, guys? Whatever so far I've discussed will also be applicable in your orthopedics also. Okay. Clear? Very good. So this is a Smith fracture. So in case of Smith fracture, you see a garden spade deformity. Garden spade deformity. So how are you telling garden spade? All of you look here. There is a straight line. There is a small bend, and again there is a straight line. यहाँ पे भी there is a straight line. There is a small bend. Again there is a straight line. So this is a garden spade deformity. So I hope you are perfectly clear with this. And remember two things. Both of these are extra-articular fractures. Now, the last fracture I want to discuss here is, look here now. This is your radius and this is your ulna. Okay? So previously fracture kahan pe hua? Fracture happened exactly at this location. है ना? Now look, where is the fracture happening? Fracture is happening exactly at this location here. So this is also a distal radial fracture only. But what is the difference? The difference is that this is an intra-articular fracture. Intra-articular fracture. Intra-articular fracture matlab fracture that is involving the joint. कौन सा joint involve हो रहा है यहाँ पे? With radiocarpal dislocation. Radiocarpal dislocation. So there is a joint that is involving, that is radiocarpal dislocation. Very good, Pradyuman. Pradyuman, actually we have to look whether it is volar displacement or dorsal displacement on the lateral X-ray only. Okay? So this kind of fracture is called as Barton's fracture. Barton's fracture. So one thing you need to remember in Barton's fracture, that is it is an intra-articular fracture with radiocarpal dislocation. Okay. Now all of you just look at this sheet which I have kept it here. Look at this. Colles and Smith, both of them are what? Extra-articular fractures. और ये भी Barton है, ये भी Barton है. Then why you did not tell? Simple thing. Fragment is going up, dorsal Barton. Fragment is going down, ventral Barton. ठीक है? But दोनों Bartons क्या है? Intra-articular. So extra-articular and intra-articular. Right. Just look at this X-ray, you'll understand. Can you see a fracture here? ये देखो, छोटा सा fracture. Can you also see a fracture here? I know the image is not that clearly visible, but try to, look at this. Yeah, that's what Salat, that's what I told, radiocarpal dislocation. Okay. So can you say it? This is a Barton's fracture. Right. So we are done with the radius as well as ulna. One last important congenital anomaly I wanted to tell you regarding this radius and ulna, that is normally your radius and ulna are straight. But there is a congenital problem where during the age of 4 to 10 years, this occurs mainly in the age of 4 to 10 years, right? So here you would see as the age grows, you will see slowly the radius bone taking a turn. For example, this is the radius bone taking a turn like S. Okay, but ulna bone is straight. ये देखो ulna straight है. So the radius is taking a turn, ulna is straight. This condition is called as anterior bowing of radius. Okay, anterior bowing of radius bone. Okay, this is called as anterior bowing of radius bone. And this condition you call as, very good Amna, made lung deformity. Made lung deformity. This condition you called as made lung deformity. Right? All of you are understanding, guys. Whatever I'm telling, all of you are understanding. Hello, Med Booster. Hi. All of you are understanding, right? So this condition we call it as made lung deformity. Just look at the picture here. Look at an X-ray. Ye dekho. Bone which is straight from here all the way here. This is ulna which is straight. But look at the radius. There is a turn in the bent in the radial bone. So this is a made lung deformity. Or yahan pe bhi dekho, the ulna bone is perfectly straight. But look at the radius bone. Again there is a bent. This is also called as what? Made lung deformity. Okay? Right. The next important thing is, all of you look at this now. All of you know this is your radius bone and this is your ulna bone. Okay? Salat, what you did not understand? Hasan, hi Hasan. Salat, I just told that ulna will be straight, radius will take a turn like this, okay? Radial bone will bend like this. So that condition you call it as made lung deformity. That condition you call it as made lung deformity. This occurs mostly you see at an age group of 4 to 10 years. So this is the only thing you need to remember, okay? Now here, this is radius and ulna. Now I'm going to tell you one fracture. Just follow whatever I'm telling you. If there is a fracture exactly here, now this is upper third of the shaft of ulna, or I can also tell that this is a proximal ulnar fracture, right? So I can tell it as upper third shaft of ulna fracture, or I can tell proximal ulnar fracture, proximal third of ulnar fracture. Along with that, you see this is the radial head. The radial head gets dislocated like this. Matlab ye radial head jo hai na, this will come out like this. So what is there? Proximal radial head dislocation. Proximal radial head dislocation. If you see these two things in a question, right, directly tell that this is Montague fracture. Montague fracture. Okay, exactly opposite of this fracture will be your Gilesi fracture. So now let us see what is exact opposite. यहाँ पे upper है, upper को opposite क्या है? Lower. Upper third है, यहाँ पे lower third, right? Lower third shaft of radius fracture, क्योंकि वहां पे upper third shaft of ulna fracture. Along with that, there was proximal radial head dislocation. तो यहाँ पे distal radio-ulnar joint dislocation. Radio-ulnar joint dislocation. And this fracture you call it as Gilesi fracture. I'm sorry if the spellings are wrong. This is called as Gilesi fracture. Okay. Thank you, Metroid. Thank you for your words. Thank you so much for your words. Thank you so much. So this is called as Gilesi fracture. Now, how do you remember? Right? If there is any fracture on the top region, right? Where is the moon? Moon is on the top. So Montague fracture. Where is the ground? Ground is in the bottom. So G for Gilesi fracture. So exactly there is a fracture at this part and the inferior radio-ulnar joint gets dislocated. Okay, so 2 fractures to remember for anatomy both as well as for orthopedics. Okay, now after this, the next important topic is this one. Okay, I'll tell you the name of the topic later. First, let me explain this. Okay, see, this is your radius bone, this is your ulna bone. Okay, so ulna is actually catching hold of radius in this way. Ye dekho, ulna is actually catching hold of radius in this way. Okay, so you see this ligament, whatever I have drawn here. Very good. Varshita has already started answering. This ligament is called as your annular ligament. Annular ligament. Okay, annular ligament. Very good. Yeah, Praduman, you are right, Praduman. Annular ligament. For example, you leave your kids near a housemaid, right? What she does, one hand she is having a rice bowl, okay? And the baby is playing on the floor. Now she won't put the rice bowl on the floor, lift the baby and again take the rice bowl and feed the baby. Yes or no? So she'll multitasking. So one hand she'll have the rice bowl and with another hand she'll lift the baby like this. Now suddenly when she's lifting the baby, what will happen is that this annular ligament which is catching hold of the radial head like this radius gets subluxated or dislocated from this like this. You're getting it? The radial head is coming out of this annular ligament. So this kind of elbow you call it as nursemaid elbow or housemaid elbow. Okay, or you can also simply call pulled elbow. Just look at the picture. This is a cadaveric image. So ye hoga tumhara ulna bone, right? So here there used to be radius. There used to be radius like this. And this ligament is your annular ligament. Annular ligament. Okay, annular ligament. So all of you see, this is the ligament. You see the radial head is popping out of this ligament. Yes or no? So this is because of the pulled elbow. And finally, what is the resultant? The resultant is the radial head has come out. Okay, so this condition you call it as nursemaid elbow or housemaid elbow, or you can also call it as pulled elbow. Pulled elbow. Very, very, very important. They are going to ask you only one thing. They are going to ask you only one thing, that is what is the ligament that is subluxated, right? Subluxation matlab dislocation. So yeah, Sachin, PDF milega pakka. Komaldeep is asking, how do you treat it? How do you treat is nothing. You need to catch hold of the hand and hyperpronate. Okay, this is pronation. You need to hyperpronate the child arm. It will get locked within the ligament back. Okay, right. Next important thing we will discuss is some of the one-liner questions which were frequently asked, guys. So all of you know these one-liner questions, by the way. Just let us discuss these one-liner questions. Thickest border of scapula. Okay, lateral border is the thickest border of scapula. And by the way, if some one-liners I did not discuss in the PDF here, when I'll put the PDF on the Telegram group, there I will discuss, put all the one-liners there. Okay. Most common fractured carpal bone, anyone? Most common fractured carpal bone? Very good. Very good. Very good. Scaphoid. Scaphoid is the most common fractured carpal bone. Most common dislocated carpal bone? Dislocated is lunate. Very good. That is your lunate. Largest carpal bone, right? Which thing do you think is the largest in your body? Head, right? Head matlab kya? Capitate. So capitate. Capitate. Okay. First carpal bone to ossify. First carpal bone to ossify is also capitate. And can anyone tell me what is the shortest metacarpal? Not carpal, shortest metacarpal. Okay. Shortest metacarpal. Very good. Abdullah, very good. Abdullah is very good. First metacarpal. Okay. First metacarpal is the shortest metacarpal. Right, guys? So now let us enter into another important topic, that is the muscles. Okay. So we shall discuss about the muscles and what are the clinical points we have to discuss there. We will discuss with images and proofs. Okay. So in the muscles, the first thing we shall be starting is the muscles of the pectoral region. Whenever I discuss the muscles of pectoral region, the famous mnemonic which I use is 2P, 2S. 2P, 2S. Okay? You know, P stands for pectoral only. So, pectoralis, one is called as pectoralis major. ठीक है, मेजर होगा तो उसके साथ माइनर होगा. Another one is called as pectoralis minor. Okay. After that, 2S. What is a 2S? One muscle below the clavicle is called as subclavius. Subclavius. और एक मसल है that is present in the lateral side of the chest, right in the upper 8 ribs. ये मसल होगा serratus anterior. Serratus anterior. So far for the exam, only 2 questions were asked, that is from the pectoralis major and serratus anterior. Okay. Pectoralis major as well as serratus anterior. Now, before we discuss the complete details of this, one very important point I want to share with all of you, that there is one clinical condition. Okay. In this clinical condition, what will happen is that this pectoralis major muscle, very good Komaldeep Kaur, will come into that. Okay. Very good. Boxer's muscle, she's right. So there is one clinical condition where out of 2 pectoralis major, 1 pectoralis major is absent completely. So can I call it as unilateral chest wall hypoplasia? है ना? इसके साथ साथ, right, along with this, you will also see underdevelopment of the fingers of your hand as well as the forearm is also underdeveloped. Okay, this condition where you see unilateral chest wall hypoplasia. इसका मतलब क्या है? That is pectoralis major is absent. Pectoralis major muscle is absent. And this condition you call it as, very good, Abdullah, you are right. Abdullah, Amit Kumar, Amna, perfectly right. This is called as Poland syndrome. Okay, Poland syndrome. Just look at the picture. Ye dekho. So here, tell me which chest wall hypoplasia is there, right or left? Right or left? बताओ. Divide कर लो. Divide like this. This is right, this is left. So right sided unilateral chest wall hypoplasia. And you can also see all the fingers of the hand are also underdeveloped, right? So this, if they give these 2 combinations, will you answer it as Poland syndrome or no? You have to answer it. Okay, right. Now after this, the next important thing we shall discuss is the nerve supply. Now regarding the nerve supply of these 4 muscles, all of you know ABCD, all of you know LMNOP also, right? L, M, N, O, P, Q, R and so on, है ना? Now what does L stands for? L stands for lateral and medial pectoral nerve. Lateral and medial pectoral nerve. Okay, lateral and medial pectoral nerve. M stands for only medial pectoral nerve. Medial pectoral nerve. Okay. N stands for, very good, you're super fast guys, very good, I'm really happy, nerve to subclavius. And O stands for long thoracic nerve. Long thoracic nerve. L stands for long thoracic nerve. Okay, L stands for long thoracic nerve. Now all of you look at this. You see this muscle, this large muscle which is present all the way here, है ना? ये muscle जो है ना, this is called pectoralis major muscle. If they give such picture and point an arrow, you should answer it as pectoralis major. For example, if I'm cutting this pectoralis major like this and I'm removing it like a flap, है ना? Under you will see a small muscle. This is called as pectoralis minor muscle. This is called as pectoralis minor. Clear? All of you are clear with this? Right. Now, after in pectoralis major, one clinical point we discussed Poland syndrome. In serratus anterior, all of you can see the serratus anterior muscles here. You can see some muscles on the lateral side of the chest wall here. Very good. With serrated margins, है ना? These muscles are called as serratus anterior. Serratus anterior. Just now we discussed serratus anterior is innervated by which nerve? long thoracic nerve. है ना? Serratus anterior is innervated by long thoracic nerve. Okay, long thoracic nerve. For example, what is the use of serratus anterior? Guys, all of you now, I want your full attention to whatever I'm going to teach you now. Now, see, boxers, what do, guys? They punch like this. You know? When they are punching, this punching action, whenever you are punching, the scapula is moving forward. The scapula is not moving backward. When you are punching like this, the scapula is moving forward like this. Right? So, while pushing the doors or while punching anyone, right, the only muscle which you need is serratus anterior. What does the serratus anterior do? It will push the scapula forward, which means it is called as protraction of scapula. Okay, so in boxers, this muscle is called as a boxer's muscle. Why? Because in boxers, this muscle performs a powerful protraction. Okay, so two important things I want to write here, that this serratus anterior is also called as boxer's muscle. Boxer's muscle. क्यों? क्योंकि this performs powerful protraction. Powerful protraction of scapula. Okay? Powerful protraction of scapula. So where is this nerve, guys? This nerve is not deep inside. You see, this nerve is exactly located above the ribs like this, right? This nerve is passing like this. So if I give a hard blow here, right, a blunt injury, or if I hit hard, this nerve will be damaged. Agar ye nerve damage hua, then serratus anterior muscle is not working. If serratus anterior is not working, can you do a punching action? No. Can you even at least push the doors? You cannot push the doors. This condition is called as complete winging of scapula. Okay. So, long thoracic nerve injury would lead to complete winging of scapula. Complete winging of scapula, right? So, don't just tell winging of scapula, it is complete winging of scapula. Clear? Complete winging of scapula. Sir, why are you telling it specifically as complete winging? Because there is also something called partial winging of scapula. There is also something called as partial winging of scapula. Partial winging of scapula, very, very good. Very good. You are answering very good. Partial winging of scapula is because of a nerve called as spinal accessory nerve. And spinal accessory nerve is supplying what? It is supplying your trapezius muscle. So, agar trapezius paralyze hua to partial winging of scapula. Agar serratus anterior paralyze hua to complete winging of scapula. If long thoracic nerve is damaged, complete winging of scapula. If spinal accessory nerve is damaged, partial winging of scapula. So, these are the hardcore points I want you to remember, guys. Very, very, very important for your exams. Very, very important. Okay, so all of you just look at the picture here. Ye dekho. You see winging here, right? So this winging is called as complete winging of scapula. Okay, so this is called as complete winging of scapula. Okay, so this is all you need to remember regarding this. But one last thing I want to tell you is that, guys, nowadays they are putting a cadaver and asking you the landmarks. Okay, so one important landmark I want to share with all of you. Just look at this picture here. Ye dekho, look at this clearly. Can you see serratus anterior muscles here? Ye dekho, here you have got serratus anterior muscles like this, right? I hope all of you can see. Now exactly on the top of this serratus anterior, can you see a string that is coming down all the way? Ye dekho. This string which is coming down all the way is called as your long thoracic nerve. Okay, all of you can look at this image. Can you figure it out, yes or no? Rizaldi, very good Rizaldi. Very good. So this is your long thoracic nerve. This one is your long thoracic nerve. And once in the exam they ask what is the root value of long thoracic nerve. The root value is C5, C6, C7. Keep this thing in mind. Okay? Long thoracic nerve is C5, C6 and C7. So till here whatever we discussed, all of you understood, guys? Yes or no? Everyone perfectly understood? Yeah, very good. Now the next important thing, just do this question, guys. A 49-year-old, you are very good, very good. A 49-year-old photographer presents to his primary doctor for annual physical. You know, while conducting the physical exam, you note that he has decreased range of motion in his right shoulder, along with what is seen in figure A. Figure A, you see this. This is complete winging of scapula. So overall, कौन सा nerve है? Long thoracic nerve. Long thoracic nerve. ठीक है? Right. The next important topic we shall be discussing right now is clavipectoral fascia. ठीक है? Clavipectoral fascia मतलब the fascia that is present between clavicle and pectoralis minor is called clavipectoral fascia. So all of you look here now. This is your clavicle. ठीक है? Clavicle के नीचे बिल्कुल what is the muscle that is present? Subclavius. So this is your subclavius muscle. ठीक है? और this muscle over here is your pectoralis minor muscle. ठीक है? Minor के सामने क्या होगा? Major. So this entire muscle you see is pectoralis major muscle. Pectoralis major muscle. Okay? Now this fascia which I am highlighting it with the green, you know, this fascia is called as your clavipectoral fascia. This one is called as your clavipectoral fascia. The only question that is all the time asked is what are the structures that are piercing the clavipectoral fascia, है ना? देखो यहां से ना कौन सा nerve जा रहा है ऐसे, what is the artery that is going, what is the vein that is going, this is what they will ask you. Okay, now in clavipectoral fascia, what are the second two letters? L and A, है ना? L as well as A. Now look at what is L and A. L stands for lymphatics. L stands for lymphatics. Okay? L also stands for lateral pectoral nerve. L also stands for lateral pectoral nerve. Next A. A stands for axillary artery. A stands for axillary artery. A also stands for axillary vein. Okay? So is axillary artery directly penetrating that? No. A branch of axillary artery called as thoracoacromion artery. Thoracoacromion artery. And is the cephalic, is the axillary vein directly piercing? No. Branch of that is cephalic vein. So these are the structures that are piercing your clavipectoral fascia. All of you understood? Everyone perfectly clear? Yeah? All of you understood the clavipectoral fascia? In my detailed lectures and all, when you have time, right, you can watch about clavipectoral fascia. I've talked about 40 minutes, right? So detailedly I talked there, but this is a rapid review session. But anyways, at the end, what they ask is important. है ना? These are the things that are important. So L and A. Chalo. All of you are telling yes. Let us see how much you have learned now. है ना? Clavipectoral fascia is pierced by all but one of the structures. बताओ. Which structure is not piercing the clavipectoral fascia? Just tell me the option A, K, B, C, D, E. What is that? Pradyuman, what happened? Pradyuman? Amit Kumar is telling E. Very good, Amit. Komaldeep Kaur, why? Komaldeep Kaur, cephalic vein is a part. मैंने बताया था ना? See, cephalic vein is there. Okay? Dharan Sai again, not B. Cephalic vein is piercing. Pectoralis minor muscle है. How will muscle pierce the fascia? है ना? Muscle. This is not the thing. Yeah. Which of the following structures does not pierce the clavipectoral fascia? Batao? Which of the structures does not pierce? The same question they asked. Lymphatics, they are there. है ना? Medial pectoral nerve, तो acromiothoracic axis नहीं, artery. ठीक है? Thoracoacromion artery और acromiothoracic artery. Lateral pectoral nerve, cephalic vein. But medial pectoral nerve is very good. All of you answered perfectly. Very, very, very good. Very good. So, this and clavipectoral fascia, say guys, pakka there will be a question. And so far at the fractures which we discussed from orthopedics or from anatomy, they will definitely ask you 2 questions. Okay, keep this thing in mind. Now the next topic we shall be entering is the apex of axilla. Apex of axilla. Okay, we shall discuss the apex of axilla, at the same time base of axilla also. Apex of axilla is also called as cervico axillary canal. Cervico axillary canal. Okay, just look at this thing before I discuss that. All of you look at this. Here, this is the anterior side. Samne se hai ye, hai na? This is the anterior side. Now, if I am looking from the top, you can see 3 things. Samne clavicle hai, right? On the back, you have got scapula, and on the medial side, you have got the first rib. Hai na? Dekho, this is anterior, this is from the superior view. So, clavicle, scapula, as well as the first rib. Now, let us go back. Here dekho. You have got clavicle anteriorly. Anteriorly, you have got clavicle. Okay? Posteriorly, you have got scapula. And medially, you have got the first rib. You have got the first rib. Now, can you see a small canal in between all these 3? This canal is called as cervico-axillary canal. Okay? Only one question they will ask you, that what are the borders of cervico-axillary canal? You know now, hai na? Anterior clavicle, piche what? Scapula, and medially first rib. So, after this, from the axilla here, from the apex, if I am going down, hai na? Ye apex, from the apex, if I am going down, the base is getting broader and broader. Hai na? So, this is called as the base of the axilla. So, now we shall discuss what are the structures of base of the axilla. Base of axilla. So, in the base of axilla, what are the things you can see? So, I am putting my arm like this. Hai na? Ye dekho. This is the base. In this base, medially I have got ribs. Hai na? Medially I have got ribs. Laterally I have got humerus. Or piche kya hai? Posteriorly I have got scapula. Again, medially ribs, laterally humerus, and posteriorly I have got scapula. So, these are the borders of the base of axilla. Just look at the picture now. Medially I have got ribs. Medially I have got ribs. Posteriorly I have got scapula. And laterally I have got humerus. Laterally I have got humerus. Okay? All of you understood till here, because this is the most important thing. Right. Next important thing is in the humerus. Okay? If you look at the humerus like this, guys, if you look at the humerus, this is the humerus. Hai na? All of you know, wherever there is head, that is a medial side. Matlab, ye green color. So here you have got, this is called as a medial lip, है ना? और ये जो है ना, this is called as a lateral lip. एक है medial lip, एक है lateral lip. Now, one thing to remember, what muscle is attached to medial lip, what muscle is attached to lateral lip, and what muscle is attached in between both the lips, which is also called as bicipital groove. So, the muscle that is attached to medial lip, how do you remember? Remember it as like this, MET, MET. MET क्या होता है? Right? MET stands for medial lip. To this medial lip, what muscle is attached? T. T stands for teres major. T stands for teres major. Okay? And for lateral lip, what is attached? Another major is attached. What is another major? Not psoas major. Okay? Psoas major mat likhna. What is another major? Pectoralis major. Very good. For lateral lip, there is pectoralis major. Okay? So here you have got, this is a very important question, guys. On the medial lip, you have got teres major. On the lateral lip, you have got P major, that is pectoralis major. और दोनों के बीच में, है ना, In between both of them, you see this blue color thing which I am drawing here. This is a bicipital groove. Or is bicipital groove mein kya hai, guys? What is in this bicipital groove? Bicipital groove is consisting of, very good, latissimus dorsi, simply called as lats. Latissimus dorsi or lats. Okay, guys, when this was a question one time they asked, okay, so what is a muscle that is inserting to, I don't remember exactly, but they asked regarding these two lips and one groove. Okay, so they asked what is that muscle that is attaching to medial lip, or what is a muscle that is attached to lateral lip, or what is a muscle that is present in the bicipital groove. This is very important. I'm telling you, just remember it. Okay, so why did you tell me that? The reason is that will be applicable in this concept here. Now, all of you look, just below the scapula. Scapula is dome shaped. ये ऊपर वाला जो है ना, this is suprascapular region, है ना? This is the dorsal side of the scapula, and this region is the ventral side or subscapular region. यहाँ पे जो muscle होगा ना, this muscle is called as subscapular muscle. Okay, so there is a muscle that is located here. This muscle is called as subscapularis muscle. So this is subscapularis. Okay, after this you have got, let us say this is lateral lip, okay, और ये होगा medial lip. Now you will tell me medial lip कौन सा muscle? What is a muscle in the medial lip? Come on, answer first. अभी तो बताया, just now I told you. Very good, very good. To the medial lip, you have got this muscle called as teres major. This is teres major. Okay, and for the lateral lip, pectoralis major. ये देखो, pectoralis major on the lateral lip. This is your pectoralis major. ठीक है, pectoralis major के नीचे कौन सा muscle होगा? Pectoralis minor. So this muscle is pectoralis minor. Okay, and in between both of them, what muscle do we have? Latissimus dorsi. So this muscle in the bicipital groove is your LADS, latissimus dorsi, right? And I told you on the ribs here, you have got a muscle which is serrated. And what is that serrated muscle here? Serratus anterior. ये देखो, यहाँ पे होगा serratus anterior. This is your serratus anterior muscle, right? Now what I will do is that, guys, I am drawing a line like this. ठीक है, जो भी line के सामने है, this is the anterior side, line के पीछे posterior side. Okay, and humerus, you know, it is on the lateral side, and the opposite side will be the medial side. Now the question which they're gonna ask you is that anterior wall of the base of axilla is made up of, lateral wall is made up of, medial wall is made up of, posterior wall is made up of. Okay, so all of you just look at this thing which I have written already. Anterior wall पे क्या क्या है? Anteriorly we have got pectoralis major and minor. ये देखो, pectoralis major and minor. Posterior wall, posteriorly क्या क्या है? One we have subscapularis, one we have got teres major, one we have got latissimus dorsi, है ना? So all those three muscles are located posteriorly. And medial wall is having only one muscle that you called already it as serratus anterior, है ना? ये देखो, serratus anterior. Okay, serratus anterior, right? Lateral wall, on the lateral wall what do you have? You have got humerus. Okay, humerus के साथ साथ two muscles, short head of biceps and coracobrachialis. I agree that I did not draw these muscles here. I don't want to make it up a mess. So just remember these two muscles out of the box. Short head of biceps and coracobrachialis. These are the borders of the base of axilla. Okay, now they are going to ask you, ये axilla के बीच में, in this, what are the contents? What are the contents you have? The contents which I have here is, you can remember by a mnemonic, JUTA, L-I-A-R, liar, right? Now what does L stand for? L stands for long thoracic nerve. Sir, what long thoracic nerve is doing here? Long thoracic nerve should supply your serratus anterior. You know? Next, after L, I stands for intercostobrachial nerve. intercostobrachial nerve. फिर से I also stands for infraclavicular part of brachial plexus. Infraclavicular part of brachial plexus. And 4 here stands for A. What is A? A stands for axillary artery. A stands for axillary vein. A also stands for axillary lymph nodes. Axillary lymph nodes. And finally, A stands for axillary tail of breast. Axillary tail of breast. Axillary tail of breast. Okay? So all of you understood, guys? All of you understood regarding the axilla? Very, very important topic. High yield topic, I'm telling you. All of you are clear with this? Yes? Be fast. Pradyuman, you are clear? Osama Sheikh, welcome back. Osama, you are clear with this, whatever I've taught? Nagesh, you are here? Right. The next important topic we shall be discussing, guys, and again I'm telling you these MCQs at the end, kyunki I know definitely you will answer it right now. Okay? I don't want, yeah, you will answer these questions right now because abhi topic bataya maine, hai na? Right. So, the next important topic is brachial plexus. All of you know, no need to tell how important it is, right? Can anyone tell brachial plexus originates from? Yeah. The first important point is brachial plexus originates from ventral rami of C5, C6, C7, C8 as well as T1. Okay. The second important point which you need to know is that, you know, even C4 also, C4 spinal segment also gives some contribution. C4 से भी कुछ nerves आएंगे. Not only C4, after T1, T2, T2 से भी कुछ nerves आएंगे, right? So there is some contribution. So there is a little contribution. So there is a little contribution from C4 as well as T2 also. Okay. Third important thing is that, for example, let us say from C4 many nerves are coming and from T2 no nerve is coming. This kind of brachial plexus is called prefixed brachial plexus. Okay. In the same way, from C4 no nerve is coming and from T2 many nerves are coming. This is called post-fixed brachial plexus. Okay. So there are two types of brachial plexus where C4 contribution is large and T2 has got no contribution. Very good, Pradyuman. This is called as prefixed brachial plexus. Okay, exactly opposite of this. इसका opposite जो है ना, opposite, that is called as post-fixed brachial plexus. Post-fixed brachial plexus. Now let us look at the brachial plexus, guys. In this brachial plexus, there are three parts. This is the first part, supraclavicular part. Behind the clavicle is called retroclavicular part. After the clavicle is called as infraclavicular part. Supraclavicular part say we get only roots and trunks. Retroclavicular part say we get divisions. Infraclavicular part we get cords. Okay, we get cords. Now, all of you know this line, roots, trunks, divisions as well as cords. Now let us draw the brachial plexus. Very, very, very easy. Rini Atkinson, you don't understand. Now you understood whatever I've told about prefix and postfix, Rini. Hi, Ramya. Right. Now let us see. Let us draw along with me. Okay? Draw along with me, all of you. So from C5, C6, C7, C8 and T1, what are the branches that are coming out? See, all of you look here now. This is called as C5 root. This is called as C6 root. This is called as C7 root. This is called as C8 root. And this is called as T1 root. So we have covered the roots of brachial plexus. Okay. Now what will happen? C5, C6 together they join roots के बाद क्या होगा? We have got trunks. C5, C6 join together to form a trunk. In the same way, C8 and T1 join together to form another trunk. And C7 has nothing to join, so it is left alone. So we have got three trunks: superior trunk, middle trunk, as well as inferior trunk. Okay. Now, after the trunk, we have got divisions. All of you look at the divisions. We have got one posterior division. ये देखो, ये जो division है ना, this is posterior division. And we have got one anterior division. This is anterior division. फिर से, we have got a posterior division. We have got a anterior division. Again, we have got a posterior division. We have got an anterior division. Okay. So what will happen with these posterior divisions? All these posterior divisions, they join together and they form a cord called as posterior cord. Posterior cord. Okay. Next, anterior divisions of C5, C6 and C7, दोनों मिलके they will form a cord called as lateral cord. Lateral cord. And C8 and T1 alone forms a cord. This is called as medial cord. This is called as medial cord. So that's it. Very, very, very simple thing, guys. So exactly follow the same way I taught you. It would be really simple for you to understand the brachial plexus. So what are the additional things you want to tell? Additional things are, there are just three nerves that are coming from the top. Okay. Ye dekho. From the trunk, there is one nerve that is coming like this. There is a nerve that is coming from the top. There is a nerve that is coming from the bottom. Okay. So nerve which is on the top is always called supra, you know. So this is called as suprascapular nerve. Suprascapular nerve. And nerve which is on the bottom is called as nerve to subclavius. Nerve to subclavius. One is suprascapular nerve, nerve to subclavius. Okay. और एक nerve है. There is one more nerve that is coming all the way from the root of C5 itself. This is called as dorsal scapular nerve. Dorsal scapular nerve. Okay. When I was telling you serratus anterior, I told you the root value of serratus anterior क्या है? C5, C6 and C7. Right? ये देखो. From C5, C6 and C7, you see a long nerve that is coming. That is why it is called as long thoracic nerve. Long thoracic nerve. Okay? Now, let us see. Very good, Meenakshi. It is long thoracic nerve, C5, C6 and C7. Now, let us see what are the branches of posterior cord, what are the branches of lateral cord, and what are the branches of medial cord. Okay? So, all of you look at the branches here. Small mnemonic to remember that. Posterior cord you can remember by mnemonic ulnar. Okay? Ulnar. Lateral cord by LML. LML. And medial cord by M4U. M4U. Okay? Now let us see what is U. What is U? Anyone? U stands for ulnar. U doesn't stand for ulnar. You know, life is not simple. U stands for upper subscapular nerve. Upper subscapular nerve. Okay? Next, when I tell U for upper subscapular, then L for क्या होगा? L for lower subscapular nerve. Lower subscapular nerve. ठीक है? Osama Sheikh? नहीं. हाँ, very good. Next, N here. N stands for nerve to latissimus dorsi. I'm just writing it as LADS. Latissimus dorsi. And fourth important thing, A. All of you know A, the famous nerve, axillary nerve. A stands for axillary nerve. And R, the last word R stands for, yes, very good, very good, radial nerve. Very good, radial nerve. Okay? Fine. इसके बाद, the next thing we have is LML. Okay? LML क्या होगा? L here stands for lateral pectoral nerve. Lateral pectoral nerve. Right? M here stands for musculocutaneous nerve. M here stands for musculocutaneous nerve. And third important thing, L again stands for lateral root of median nerve. Lateral root of median nerve. Okay? Lateral root of median nerve. So this is the lateral cord. Now when it comes to medial cord, what are the branches? M stands for, ये देखो यहाँ पे lateral pectoral nerve है. If there is lateral pectoral nerve, there should also be medial pectoral nerve. Medial pectoral nerve. Next important thing, there is a cutaneous nerve. Okay? There is a cutaneous nerve for your forearm, sorry, for your arm, for your forearm. So what you will call it as medial cutaneous nerve of arm, medial cutaneous nerve of forearm. Okay? Medial cutaneous nerve of arm, the same thing, medial cutaneous nerve of forearm, okay? And the final thing, U, yes, U stands for ulnar nerve. Very good. U stands for ulnar nerve. Very good, Faith Tolentio. Very good, very good. U stands for ulnar nerve. So these are the nerves of your brachial plexus. Now let us see what are the structures that are injured in brachial plexus. What are the clinical scenarios in brachial plexus? Okay? So regarding the clinical scenarios, there are two important clinical scenarios, guys. One, all of you know, that is called Erb's palsy. Another one is called as Klumpke's palsy. Okay? So when does Erb's palsy will happen? Erb's palsy will happen out of C5, C6, C7, C8 and T1. Erb's palsy will happen when there is injury to C5 and C6. Okay? And Klumpke's palsy will happen when there is an injury to C8 and T1. So can I tell? Yeah, I'll give break. Don't worry. So can I tell that C5, C6 together, you call it as upper trunk lesion? Upper trunk lesion. And in the same way, C8 and T1 is called as lower trunk lesion. One is upper trunk lesion, another one is lower trunk lesion. Okay? इसके बाद मैं break दे देता हूँ. Next important thing is that Erb's palsy is also given some names. What are the names? One is called as policeman tip deformity. Okay? Policeman tip deformity. Or you can also call it as waiter's tip deformity. Or you can also call it as porter's tip deformity. Porter's tip deformity. Okay? Porter's tip deformity. So these, very good. Shams, Shaifullah Shams, very good. So these are the names that are given. So what will happen in Erb's palsy, guys? What will happen is that, you know, these C5, C6 is located superficially, right? So whenever you're pulling the baby out, right, there is a condition called shoulder dystocia. Shoulder dystocia matlab, the shoulder is against the pubic tubercle. Okay, so as you can see the picture here, the shoulder here is impacted matlab obstructed against this bone, pubic tubercle. Now when you are pulling it, what will happen? The angle between the neck, the head as well as the shoulder is increased like this. You're getting, the angle is increased. So when the angle is increased, what will happen? The C5, C6 lesions, C5, C6 trunks, whatever are there, they get injured. Okay. So this condition you call it as shoulder dystocia. And second important thing is that, for example, I'm sitting under a tree, instead of apple, if there is a heavy branch that is falling on my shoulder, tab kya hoga? Superficially, you have got C5, C6. Again, C5, C6 injury will lead to Erb's palsy. So main two causes are shoulder dystocia during the delivery and heavy weight fall on the shoulder. These two things will lead to Erb's palsy. Now in Erb's palsy, how will the patient present? So this is how the presentation is. This is how the Erb's palsy looks. Now my arm is moving laterally towards my body, right? It is adducted. My arm is adducted. And next, my arm is pronated and internally rotated like this. You're getting it? Adducted, pronated, and internally rotated. Okay? My arm is adducted, right? Internally rotated, and pronated. Okay? Why my arm is adducted? Can anyone tell why my arm is adducted? Because abductors are not working. Why my arm is internally rotated? Because external rotators are not working. Why my arm is pronated? Because supinators are not working. Clear, all of you? Right? So this is a very important question, and the next important question they're going to ask you is that what are the muscles that are involved in Erb's palsy? A simple mnemonic I'll give you. Remember it as beside. Why beside? Because your arm is not away. Your arm is beside by you itself, है ना? Your arm is adhered to the chest wall like this beside you. So beside. B stands for biceps brachii. B stands for biceps brachii. B also stands for brachialis, and B also stands for brachioradialis. Brachioradialis. Okay? All the three B's are finished. Three B's are finished. Then S. What is S here? S stands for supinator and supraspinatus. Supinator and supraspinatus. Okay? Yes, B ho gaya. When I tell supraspinatus with S, then what should I tell with I? I stands for anyone? Infraspinatus. Very good. Very good. Infraspinatus. Next, I के बाद क्या है? D. What does D stand for? Deltoid. D stands for deltoid. And finally, E stands for extensor carpi radialis longus. E stands for extensor carpi radialis longus. Okay. So these are the muscles that are involved in case of Erb's palsy. Very, very, very high yield. Okay. So this is all you need to know regarding the Erb's palsy, guys. When it comes to the Klumpke's palsy, one very important thing you need to know that Klumpke's palsy is because of C8 and T1. So it is a lower trunk lesion. In Klumpke's palsy, what is happening? Hyperabduction of shoulder. For example, let us say I am sitting on the top of the tree and suddenly when I am falling down, in the process of falling down, I see another branch. So I'll catch hold of the branch. When I'll catch hold of the branch, my arm is hyperabducted like this, right? In that case, Klumpke's palsy will happen. Second important thing is difficulty in breech delivery. Breech delivery matlab normally near the vagina, the head of the baby should be there. This is called cephalic presentation. So that you catch over the head and pull the baby out during the parturition. Instead of the head, if let us say the hips and the lower limb is facing towards the vagina, don't you think it is difficulty to deliver the baby out? Such kind of presentation is called as breech presentation or breech delivery. In that case also you will have Klumpke's palsy. Okay. So in Klumpke's palsy, what muscles are involved? What muscles are involved are all intrinsic muscles of hand. All intrinsic muscles of hand. Okay? Intrinsic muscle, all the muscles which are located in your hand. The muscles which are located in your hand here are supplied by two nerves. One is called ulnar nerve and another one is called as median nerve. So in Klumpke's palsy, will both these nerves be involved? Yes. So all of you now pay attention to whatever I'm telling you, right? Ulnar nerve supplies this part, the ulnar side. Median nerve supplies the 3.5 fingers. Laterally 3.5 fingers. And this is ulnar, this is median. Agar ulnar nerve damage hua, then these two fingers will bend like this. Agar median nerve damage hua, then these three fingers will bend like this. So totally when you see this hand is looking like a claw, that is why you call it as claw hand. Okay. That is why you call this as a claw hand. So from today onwards, if someone is asking you what are the nerves that are injured in claw hand, you have to tell it as both ulnar nerve as well as median nerve is injured in claw hand. Right? Median nerve is injured in claw hand. So only claw hand is a deformity which you see in Klumpke's? No. Along with claw hand, I see another thing also. What is that? So from C8 till T1, out of this C8 to T1, if the T1 part is injured, right? The exact way to tell is white ramus of T1, not just T1. This is white ramus of T1. If white ramus of T1 is damaged, that would lead to a syndrome called Horner syndrome. Horner syndrome. Very good, guys. All of you are answering very nicely. Very good. Faith Tolento, very good. I'm sorry if I've spelled your name wrong. Shaifullah Shams, very good. Very good, Shaifullah. Pradyuman, very good. So, white ramus of T1, don't just tell it as T1. White ramus of T1 will lead to Horner syndrome. Okay? Horner syndrome, what all things you see? What all things you see in Horner syndrome? First thing, unilateral ptosis of eyelid. Unilaterally, there is ptosis. Okay? Eyelid droop हो जाएगा ऐसे. Second important thing is, if you look at the pupil, right? The pupil is constricted only on one side. So, unilateral meiosis. Unilateral meiosis. Third important thing is, one side of the face, there is no sweating. So, unilateral anhidrosis. Anhidrosis. And last important thing is, you will also see anophthalmos. Don't put it as exophthalmos. It is anophthalmos, right? So you see he is a Dolan by, right? Dolan Trump. Yeah. Donald Trump. I'm sorry. Donald Trump. Donald Trump. You see here, there is ptosis of one of his eyelid. Ptosis. If you look at the pupil is also constricted here. The pupil is also constricted, and one side of this face, there won't be any sweating, right? So look at the patient also here, the real patient here. Ptosis, and look at the eye, this one. There is meiosis, yes or no? Constriction of pupil. Compared to the other side, here you see a constricted pupil, that is meiosis, right? So again, this patient on one side, there will be no sweating. So this condition is called as Horner syndrome. And where do you see Horner syndrome? You see when the white ramus of, yeah, Modi ji effect. I agree, right? White ramus of T1, white ramus of T1 injury. All of you understood, guys? All of you understood this, whatever I've taught now? Right, till here, all of you have understood? Just a second, yeah. So all of you are perfectly clear, right? You guys want a break or shall I continue? Continue, okay. Right. Next important thing, next important question that is asked is next important. Hello, Anand Prakash Gupta. Hello, good evening. Right, you are late. Next important thing is cubital fossa. Okay. Now, this is your cubital fossa. In this cubital fossa, you have got two parts. This is called as medial epicondyle. This is called as lateral epicondyle. So, if someone is asking you what are the borders of cubital fossa, before that, one very important thing you need to know is that from the medial epicondyle, you have got a muscle that is coming all the way down. Ye dekho, from the medial epicondyle, you have got a muscle that is coming all the way down, and this muscle is your pronator teres. Pronator teres. Okay? Now, from the lateral epicondyle also, you have got a muscle that is coming down, and this muscle is called as brachioradialis. Brachioradialis. Okay, Rini Atkinson, you asked me some doubt regarding prefixed and postfix. Just remind me at the end here, okay? So I'll clarify that to you. So medial epicondyle, pronator teres, lateral epicondyle, brachioradialis. So if someone is asking you what are the borders of cubital fossa, what will you tell? The base is formed by an imaginary line drawn all the way touching lateral to medial epicondyle. This is the base. Next, medial border is formed by pronator teres. Lateral border is formed by brach. What are the structures that are located within the cubital? Very good. R stands for radial nerve. R stands for radial nerve. T stands for tendon of biceps. T stands for tendon of biceps brachii. Tendon of biceps brachii. A stands for an artery. कौन सा artery है ये? Brachial artery. A stands for brachial artery. And N stands for a nerve. N for nerve. What nerve? Median nerve. Median nerve. So these are the structures that are located from the lateral all the way down till the medial epicondyle. Medial epicondyle. So this is all you need to know regarding the cubital fossa. Okay, this is all you need to know regarding the cubital fossa. Now, all of you understood the cubital fossa, right? Only one mnemonic to know, and the borders lateral to medial, pronator teres, brachioradialis, lateral to medial is this one. All of you understood? Is my screen okay? Screen struck. Now good? Okay, right. Right, fine. So here you can see one more thing. So this is the image that will be asked in your exam, guys. If they give such direct image and if they ask you what are the structures, what will you tell? This is your pronator teres. This is your pronator teres. This is your brachioradialis. Brachioradialis. And this is the R part. What is that R part? R part stands for your radial nerve. And this is the tendon of biceps brachii. A stands for an artery and N stands for a nerve that is called as median nerve. That is called as median nerve. Okay. So this is all the important things which you need to know here. Okay. Now let us discuss one more important thing regarding the branches of axillary artery. Okay, all of you know how important this axillary artery is. Okay, now in this branches of axillary artery, there is nothing new here. Everything is same. Here you see coracoid process, all of you. ये देखो ये coracoid process है. Coracoid process से कौन सा muscle निकल रहा है? That is pectoralis minor. And next important thing, from the medial lip, there is again one muscle is coming that is called as teres major. I told you, MET, medial lip for teres major. Okay. So the same picture, while removing some structures, I am putting the naked picture over here. I have removed some structures. So here, if you see here, this is called as the first strip. Okay, this is called as the first strip. Now after that, right, after that, here you call it as a coracoid process. This is your coracoid process. And this muscle over here is your pectoralis minor muscle, and this muscle here is your teres major muscle. Now, what are the branches of axillary artery? Before discussing the branches of axillary artery, very important thing you need to discuss here is that this artery is called as subclavian artery. Okay, subclavian artery passes all the way till the lateral border of first strip. Okay, so subclavian artery passes till the lateral border of first strip. So from the lateral border of first strip, the artery which starts is called as your subclavian artery. Okay, from the lateral border of first strip, the artery which starts here is called as your axillary artery. So this entire part is called as your axillary artery. So axillary artery starts from lateral border of first strip, all the way down till the lower border of teres major, all the way till the lower border of teres major. So what are the branches, guys? What are the branches you see here? Yeah. Remember one thing, pectoralis minor muscle, whatever is there, is dividing the axillary artery into three parts. है ना? Pectoralis minor के ऊपर जो है ना, that is called as the first part of axillary artery. Pectoralis minor के पीछे जो है ना, that is called as the second part. And after the pectoralis minor, this is called as the third part. That is the reason why pectoralis minor is called as a key muscle of axilla. Key muscle of axilla. So now you understood why pectoralis minor is called as a key muscle of axilla. This is the only reason. Okay. Now let us discuss what are the branches which we have here. Regarding the branches, first part gives one branch, second part gives two branches, third part gives three branches. So first part gives one branch, second part gives two branches, and third part gives three branches. How do you remember the mnemonic? 6 teens love songs and poems. 6 teens love songs and poems. Now you will answer me, guys. All of you answer me. What is S standing for? What is S standing here? Very good, very good. Perfectly good, perfectly good. Very good. So S here stands for superior thoracic artery. Superior thoracic artery. S stands for superior thoracic artery. T stands for thoracoacromion artery. Thoracoacromion artery. T stands for thoracoacromion artery. Next, L stands for lateral thoracic artery. Lateral thoracic artery. Okay. And S and poems. S stands for subscapular artery. Subscapular artery. And A stands for anterior circumflex humeral artery, and P stands for posterior circumflex humeral artery. So these are the branches of axillary artery. Okay, you just need to remember from where axillary artery is starting and from where it is ending. Why pectoralis minor is called as a key muscle of axilla, and the first part, second part, third part, and all these branches. So these are the three important parts I want you to know. All of you understood this? Everyone understood this, guys? Before I move on to the next branches. Perfectly clear, right? Very good. The next we shall discuss is about subclavian artery. About the branches of very good, Anand Prakash, very good. Subclavian artery. Now, even if you look carefully, guys, this artery, whatever I've drawn here in red, hai na, ye dekho, ye wala, this is subclavian artery. You know, subclavian artery is also divided into three parts with the help of a muscle. Ye dekho, ye wo muscle. This muscle is called as anterior scalene muscle. So, anterior scalene muscle divides the subclavian artery into three parts. Okay. So, the first part. First of all, let me write down the parts here. The first part, I think the branches are already, yeah. The first part. So from the first part, what are the branches that are released? All of you look here now. There is one artery, right? There is one artery that passes all the way down, which is coming from the first part like this. Ye dekho. This artery is entering inside the thoracic cavity. So I should call this artery as internal thoracic artery. So the first part gives a branch that is called as internal thoracic artery. Okay? Internal thoracic artery ke baad, now look at the second one. Here there is a trunk that is coming like this. Okay? This trunk is called as thyrocervical trunk. What is the name of this trunk? Thyrocervical trunk. Let me write it down here. This is your thyrocervical trunk. Why are you calling it as thyrocervical trunk? Because there is one branch that supplies all the way to the thyroid gland. That is why you call it as thyro. And there is one branch which moves transversely in the neck. That is why you call it as cervical. So this artery which is supplying to the thyroid gland from the lower part, it is supplying to the lower side of the thyroid gland. So I call this artery as inferior thyroid artery. Okay. And this branch which is passing transversely in the neck, I call it as transverse cervical artery. Okay. So I hope you understood this. So the second important one is your thyrocervical trunk. So thyrocervical trunk का दो branches है, right? What are these two branches? One is called thyroid branch, that is your inferior thyroid artery. ठीक है? Another branch is transverse cervical artery, and the third branch is suprascapular artery. I did not show it to you in the picture, but just remember it as suprascapular artery. Suprascapular artery. Clear? These are the branches. After this, you have got one last branch that is coming all the way up and entering into the transverse foramina and going up. This branch is called as vertebral artery. Okay? Or one last branch is vertebral artery. Vertebral artery. Okay? So only the first part is difficult, guys. Second and third part is very easy. From the second part, only one branch is coming. That is called as costocervical trunk. Costocervical trunk. And in the same way, from the third part also only one branch is coming. That is called as dorsal scapular artery. Dorsal scapular arteries, right? So if you are feeling difficult to remember this, one small mnemonic is there. Remember with that. All of you know what is vitamin C and D. है ना? All of you know what is vitamin C and D. Vitamin VIT, ये देखो V for vertebral artery, I stands for internal thoracic artery, T stands for thyrocervical trunk, and you can follow those three branches. C and D, vitamin C क्या है? C for, what is C? C for costocervical trunk and D for dorsal scapular artery. So I hope all of you are clear with this. Everyone is clear? Perfectly clear, right? Very good. Very, very, very good. Now, the next important thing we shall discuss is the nerve injuries. Nerve injuries are very, very, very important, guys. So what we shall do is, I will discuss about all the three different types of nerves, and I will discuss what will be the physical appearance, right? So physically, how will the patient present to you? So those things also I will discuss. Okay. So these will be the maximum parts which we can discuss in the upper limb. Okay. Now, the first important nerve which we shall be discussing is radial nerve. Okay. What is the root value of radial nerve? C5 to T1 is the root value of radial nerve. Guys, one thing I'm telling you, whenever I tell radial nerve, the only compartment which should come into your mind is posterior compartment. Posterior compartment mein kaun sa muscles hai? Extensor muscles. So radial nerve supplies extensor muscles. Radial nerve is responsible for extension. These are the three golden words which you need to remember without any exception. Okay. Now all of you don't write anything. Just look whatever I'm putting it down over here. So radial nerve starts in the axilla. You know? Radial nerve is coming down like this. And you know that radial nerve passes behind, क्योंकि पीछे क्या है? Spiral groove is there, है ना? So behind it passes in the spiral groove like this. That is why I'm drawing it dotted. And then radial nerve is coming down and it is passing above. What? It is passing above the lateral epicondyle and dividing into two branches. Okay? Very, very simple and clean. Okay? So in the axilla it is coming down, passing behind in the spiral groove, coming down all the way, and it is passing above the lateral epicondyle and then dividing into two branches. Now, here one very important thing is, here it gives one branch, and this branch is called as extensor carpi radialis longus. It gives a branch called extensor carpi radialis longus. Next, it divided into two branches bola tha. What are these two branches? One is called as pin. Pin matlab kya? Posterior interosseous nerve. Pin matlab posterior interosseous nerve. Another one is superficial branch. Another one is superficial branch. Okay? So how do I remember this, sir? You can remember by a mnemonic called as RESP. R-E-S-P, RESP. Okay? In this, R stands for radial nerve, E stands for extensor carpi radialis longus, S stands for superficial branch, and P stands for pin. Okay? For example, if extensor carpi radialis longus is paralyzed, this will lead to wrist drop. This will lead to wrist drop. Okay. For example, if superficial branch is gone, superficial branch supplies the skin sensation on the dorsum of the hand. Okay. So if superficial branch is gone, then what will happen? Then there will be no sensation. Kahan pe? On dorsum of the hand. On dorsum of the hand, you won't have any sensation. And if posterior interosseous nerve is damaged, this will lead to finger drop. This will lead to finger drop. These three rules also I want you to remember. Okay? Once again, just revise with me. One is extensor carpi radialis longus gaya to wrist drop hoga. Superficial branch gaya to there will be no sensation on the dorsum of the hand. Again, posterior interosseous nerve damage hua to there will be finger drop. Right? So finger drop is this. Finger drop. Okay? Now, at multiple places, the radial nerve can get injured. Okay? First important thing. Let us say, if radial nerve is injured in the axilla, let me write it down. If radial nerve is injured in the axilla, do you think the entire nerve will work? Batao, if radial nerve is injured, do you think the entire nerve which is passing down, will it work? This entire nerve will not work. If this entire nerve is not working, extensor carpi radialis longus will not work, pin will not work, superficial branch will not work. Then what will happen? In this patient, he will have wrist drop, no sensation on the dorsum of the hand, and finger drop. This condition you call it as crutch palsy. Okay? Crutch palsy is compression of radial nerve in the axilla. Okay, this will lead to wrist drop, finger drop, and no sensation on the dorsum of the hand. Second case, if there is an injury yahan pe, okay, if there is an injury at that level, what can be the injury? Midshaft fracture of the humerus. Agar midshaft fracture of humerus hua, then again the same thing. The ECRL will not work, superficial branch will not work, pin will not work. Again, even in the spiral groove, because of midshaft fracture also, the same things you will see. Wrist drop, no sensation, and finger drop. But if you see any fracture, right, if you see any problem here, not fracture, if there is a cut injury of posterior interosseous nerve, if injury is only to posterior interosseous nerve, then posterior interosseous nerve itself will not work. But ECRL is working, superficial branch is working. So in this patient, only and only thing which you see is finger drop. There will be no wrist drop. There will be no loss of sensation on the dorsum of the hand. Right? So this condition here, you see, when there is posterior interosseous nerve injury. Posterior interosseous nerve injury. All of you are clear, guys, still here? All of you are clear? Everyone is clear? You are not confused, right? Very good, very good, very good. And one last pathological problem is, agar lateral epicondyle fracture hua. Now listen to this very carefully. If there is a fracture in the lateral epicondylar region, then now you will tell me what will happen. Superficial branch is gone, pin is gone, but ECRL, will it be affected? No. ECRL is not affected if there is a lateral epicondyle fracture. So in this patient, if you see, you will have no sensation on dorsum of hand because superficial branch gaya. Finger drop will be there because posterior interosseous nerve is gone, but no wrist drop is seen. So based upon the situations, in the question if they give situations like all drops are there and that and this is there, what might be the problem? If they tell no wrist drop is seen but finger drop and no sensation on the dorsum of the hand, then what might be the problem? So they might change the questions in this way, guys. So I want you to be perfect with this. Okay. So this is all about the radial nerve. Now moving on to the next nerve, that is median nerve. Okay. This is the median nerve. You know, every one of us know that median nerve is injured mainly at two places. Okay. What are the two places is that? I already told you. One is supracondylar region. Just now I made you to revise also fractures. Hai na? If there is a supracondylar fracture, there the median nerve will be injured. Second important thing is, you know, here we have got something called as carpal tunnel. Within the carpal tunnel, what is the nerve that is passing? Median nerve. So even in case of carpal tunnel also, the median nerve is injured. So can I tell one level of injury is higher, one level of injury is lower? So that is why supracondylar fracture is called as higher injury and carpal tunnel is called as lower injury. Lower median nerve injury. So higher median nerve injury can be remembered by a mnemonic SAP, SAP. In this, S stands for supracondylar fracture, A stands for ape thumb deformity, and P stands for pointing index finger deformity. Pointing index finger deformity. Ape thumb deformity matlab your finger is like this. Okay, it is like an ape. Your finger is not abducted, it is always adducted and kept. Pointing finger deformity is that all these plexus, when I tell the patient to make a fist, he will be able to make a fist, but he cannot bend his index finger. This is called pointing finger deformity. Okay, pointing finger deformity. Where do you see higher level of median nerve injury? That is supracondylar fracture. But when you come down, when you come little bit down, very good, Sham. Sham is telling sign of benediction. Very good. When you come little bit down, what will you see? Here, first thing, ape thumb is common. Ape thumb deformity is seen, but here there is no pointing finger. There is no pointing finger. This is a very important thing you need to know. What is the difference between higher injury and lower injury of median nerve? Pointing index finger is present in higher injury. No pointing index finger is present in the lower injury. So this is all you need to know. I'll show you the pictures. Don't worry about that. This is all you need to know regarding the median nerve. When it comes to ulnar nerve, even in ulnar nerve also the same thing. Higher injury, lower injury, right? If there is a higher injury, what is a scene? If there is a lower injury, what is a scene? Always remember, guys, always remember, any nerve you take, higher injuries, the problems will be more. Lower injury, the deformities will be less. Higher injuries, the deformities will be more. But in ulnar nerve, it is completely different. Higher injuries, the deformities are less severe. Lower injuries, the deformities are more severe. Okay. So higher injuries, you would see less severe deformity. Lower injuries, you will see more severe deformity. Okay. More severe. Very good. Very good. Ulnar nerve damage will lead to what? Don't tell it as claw hand. Tell it as ulnar claw. Claw hand is both ulnar nerve and median nerve. But ulnar nerve damage will lead to ulnar claw. Ulnar claw matlab clawing of the ulnar side like this. This is less severe injury. This is more severe injury. If you see this hand, more severe injury, lower ulnar nerve damage. If you see like this, less severe injury, higher ulnar nerve damage. I hope this injuries part is perfectly clear with all of you. Everyone is clear with this injuries part before I proceed on to the pictures? Right? Now, all of you look at this. Now, you will tell me what problem has happened to the patient. What is this condition called as? Wrist drop. Wrist drop. Renee Atkinson, what I was telling you is, if the bending is like this is called less severe. If the bending is more, this is called more severe. Right? Less severe is because of, why it is less severe? It is because of higher ulnar nerve injury. Why the bending is more severe? Because of lower ulnar nerve injury. Okay. So, very good. What is this? Wrist drop. This is wrist drop. Wrist drop is radial nerve. And you know, look at these fingers and fingers of ape. You see, almost, I'm not telling, don't judge the color here, okay? This is ape, human is human, okay? So, if you see here, both the fingers are looking similar to each other, you know? So, this is ape thumb deformity. Septum deformity. And what is this, guys? Anyone? Anyone? You should be active in answering. Only few are answering. Why few are not answering, I don't know. So freshly you have come from foreign, है ना? अभी MCI के लिए पढ़ना है. You have to start reading for MCI. The life here is different. The life in foreign is different. पुराने दिन याद आ रहे होंगे, है ना? वो बाद में, अभी पहले पढ़ाई, ठीक है? So very good. This is your claw hand. This is your claw hand. Okay, both ulnar nerve plus median nerve. Okay, very good. Klumpke's palsy, Shams, very good. Klumpke's palsy. Look at this, guys. In this picture, you can see two important things. Ek to there is a wrist drop, and look at the fingers also. The fingers are also dropped off. Wrist drop and finger drop, both of them are seen here. Agree? Wrist drop and finger drop, both of them are seen in this picture over here. Okay, right. The next important thing we shall discuss right now is your carpal tunnel syndrome. So I hope all of you know regarding this carpal tunnel syndrome, guys. Everyone know about this carpal tunnel syndrome? Very good. So in this carpal tunnel syndrome, what are the important points we shall discuss? First of all, tell me, carpal tunnel is formed by? Yes, carpal tunnel is formed by? सामने है ना? What is this? Carpal tunnel is formed by this flexor retinaculum. This is flexor retinaculum. Very good. This is flexor retinaculum. Okay. Now, only one question they're gonna ask you in this carpal tunnel is that what are the symptoms? What is the nerve that is compressed? What is the nerve that is not injured also? Okay. So first of all, let us look at the borders of the carpal tunnel. If you look at the borders of the carpal tunnel, we have got roof, we have got the floor, we have got the lateral border, we have got the medial border. Okay, so this is what is called as your carpal tunnel. Let us say I'm folding the paper right now. All of you can see, right? So this is your carpal tunnel here. Now this carpal tunnel is having four borders. है ना? ये देखो 1, 2 and 3 and 4. Four borders are resting on four carpal bones. See here. Four borders are resting on four carpal bones. One is resting on hamate, pisiform, trapezium and scaphoid. Yes or no? And you see a tunnel here. This tunnel is called carpal tunnel. And what is the floor made up of? Floor is made up of carpal bones. Right? So if you want me to write here, what are the structures I'll write? Roof is having this ligament called transverse carpal ligament or your flexor retinaculum. Your flexor retinaculum. Floor. What is floor consisting of? Floor is consisting of the carpal bones. Yes or no? Proximal row of carpal bones. Next, laterally. Laterally matlab ye. Laterally, what do you have? 1 and 2. What are these 1 and 2? Laterally, I have got scaphoid and trapezium. Scaphoid as well as trapezium. Ye dekho, laterally I have got scaphoid as well as trapezium. And medially what do I have? Pisiform as well as hamate. Pisiform as well as hamate. Medially I have got pisiform as well as hamate. So these are the borders of the carpal tunnel, right? Now, if you look into the carpal tunnel, guys, all of you know one basic thing, that in the carpal tunnel, the nerve that is passing is median nerve. Okay, I agree. Now, but how it is passing is very important. This is your carpal tunnel. This is your flexor retinaculum. Okay. Now look carefully, guys. Stop commenting. Just look carefully here. This nerve which is entering here is your median nerve. ये देखो, median nerve is passing below the carpal tunnel. After passing, the median nerve gives its branches to all the thenar muscles except adductor pollicis. It gives innervation to all thenars except adductor pollicis. ठीक है, उसके बाद it will also give innervation to your first lumbrical, it will also give innervation to your second lumbrical. So it will also give innervation to your first lumbrical and also second lumbrical. Clear all of you? Right, there is a branch of median nerve that passes above the flexor retinaculum and gives sensation to the palmar region like this. Okay, so this branch is called as palmar cutaneous branch of median nerve. Palmar cutaneous branch of median nerve. Why am I stressing this? Why am I telling you about this? The reason is that if a patient with carpal tunnel is coming to me, he will have compression of median nerve. But which nerve is not compressed? The nerve that is passing above the carpal tunnel, above the flexor retinaculum, is not compressed. So patient will have problem with the first three fingers. And when I ask the patient, do you have any problem with the sensation here? He will tell no. Why? Because the palmar cutaneous branch is passing above, so it is completely intact. Okay? All of you are clear? Yeah, this is the only thing that is spared. This is the only thing that is spared. Okay? So what are the basic symptoms that the patient will complain? The first thing, patient will tell, doctor, in this first three fingers, 3.5 fingers rather to say, I have burning sensation. Burning sensation matlab I feel someone is pricking my 3.5 fingers with needles. Okay, so this kind of sensation is called as burning sensation. Okay, he will tell there are some pins and needles sensation here. Pins and needles type of sensation. Where in the lateral 3.5 digits. Okay, 1, 2, 3 and half. Second complaint, he will tell the doctor, nowadays I'm not even able to grip the bottle which is on the table. I'm not even able to hold it properly. Why? Because the thenar muscles are getting atrophied. The thenar muscles are getting weakened. Okay, so weakness of thenar. And third important thing he will tell that, but all my sensations are normal. There is no sensory loss. There is no sensory loss over the palmar region. No sensory loss over the palmar region. Okay. So these are the things which he is gonna tell you. Now, when it comes to the contents, what are going inside the carpal tunnel? One content all of you know, that is median nerve. Median nerve. Okay. Now, second, third and fourth, these three contents are special contents. Special matlab SPL hai na? What is S? S stands for flexor digitorum superficialis. P stands for flexor pollicis longus. Flexor digitorum profundus. L stands for flexor pollicis longus. So what are the three SPLs? SPL is flexor digitorum superficialis, flexor digitorum profundus, flexor pollicis longus. Clear? So these are the structures that are passing in the carpal tunnel. All of you are getting clear? All of you are clear here? Shams is telling median claw atrophy of thenar muscle. Very good, Shams. Very good. So median nerve supplies most of your thenar muscle. So obviously Sham is right. Very good. So you understood the contents. Abhi ye dekho. Everyone know the contents. You know, I know, the examiner know. But what is the important thing is that they're gonna ask you what are the structures that are passing superficial to the carpal tunnel. This is the very important question and very easy as well. Structures which are passing superficially. In superficially, what are the first three letters, guys? Tell me. Ye dekho, SUP, है ना? Superficial में the first three letters are SUP. Yes, तो superficial हो गया. The next two letters are U and P. What is U? U stands for ulnar nerve. U stands for ulnar nerve. Not only ulnar nerve, U also stands for ulnar artery. ठीक है? उसके बाद P. What does P stand for? Palmaris longus. P stands for palmaris longus. Next, P stands for, you know this. What is this? Palmar cutaneous branch of median nerve. है ना? So let me write it as palmar cutaneous palmar cutaneous branch of median nerve, right? And second important thing is palmar cutaneous branch of ulnar nerve also. Okay, I think this is very easy way to remember, right? So you have got ulnar nerve, ulnar artery, palmaris longus, palmar cutaneous branch of median nerve, and palmar cutaneous branch of ulnar nerve, right? So clear till here, everyone? Very good. So guys, whenever any patient of carpal tunnel is coming to you, you basically do two important tests. ठीक है? पहला टेस्ट ये है कि you will bend his wrist back like this, and exactly here you will start tapping the region. When you start tapping the region, patient will have an irritational pain like a current shock, you know, that kind of pain patient will have. This test is called Tinel test. This is called Tinel test. Second important test is that you will tell the patient to flex his wrist at 90 degrees. ये देखो 90 degrees है ना? Flex the wrist at 90 degrees like this. So what will happen? The median nerve here will be compressed, right? So this is called as Phelan test. Okay? There are two important tests, Tinel test and Phelan test. ये देखो, ये कौन सा test होगा? This is Tinel test. और ये कौन सा test होगा? This is Phelan test. Tinel test as well as Phelan test. Okay? One is Tinel test and the other one is your Phelan test. Clear all of you? Everyone is clear, guys? Right. Now, before we discuss the lower limb, first we shall finish off discussing the abdomen. You know, after abdomen, we'll discuss thorax and neuroanatomy. Then last, we'll discuss about the lower limb. Okay. So here in the abdomen, one very important. This is also related to surgery also. Okay. Important thing ये है कि in this there are two important triangles. Okay, so what are the two important triangles you have to know? So you can see an yellow color shaded area, you can see a blue color shaded area. Okay, first of all, let us write down the names of this. See, this is your gallbladder. Okay, this is your gallbladder. Here you have got right hepatic duct. This is called as your left hepatic duct. Okay, after this, right and left hepatic duct together they form common hepatic duct. और ये वाला जो duct है ना, this is cystic duct. Cystic duct and common hepatic duct together they form common bile duct. Very good, Osama. Common bile duct. Now this artery which you can see is called as common hepatic artery. Common hepatic artery. Okay. So this common hepatic artery is dividing into two, right and left common hepatic artery. है ना? ये देखो, ये left. This is left hepatic artery और ये जो है ना, this is right hepatic artery, है ना? Right hepatic artery से जो branch आ रहा है, this is called as cystic artery. Cystic artery. So I hope this is something which you all have studied lots and lots of times, right? This is simple terminology which I have told you here. So here there are two important triangles. One triangle is called as hepatocystic triangle and the other one is called as Kellogg's triangle. Now all of you just concentrate on this yellow color area, guys. In this yellow color shaded area, you see some few important things. First, I am discussing about hepatocystic triangle. In hepatocystic triangle, what is the superior border? Superior border is made up of, ये देखो, superior border is having, can I tell superior border is having this one? Shall I use another? Yeah. Let me use another color. Right. So superior border is having liver. Very good. Not exactly liver. You should tell it as inferior surface of liver. ये देखो, superior border is having inferior surface of liver. Okay. और lateral border देखो, lateral border there is cystic duct and neck of gallbladder, cystic duct and neck of gallbladder. And medially what do you have? Medially you have got a common hepatic duct. Okay, medially what do you have? You have got a common hepatic duct. So you have got three, exactly the triangle is not formed, but still try to make a triangle over here. So superiorly we have got the inferior border of liver, and laterally we have got the cystic duct and the neck of gallbladder, and medially we have got the common hepatic duct. Right? All of you understood now? Let me write these things. Inferior border of liver. Laterally you have got cystic duct and neck of gallbladder, and medially you have got common hepatic duct. Okay, till here you are clear. Now when I go into Kellogg's triangle, अब ये देखेंगे Kellogg's triangle में क्या क्या borders है. Okay, in Kellogg's triangle if you see here, I'll draw with the pink over here, है ना. Kellogg's triangle, you see, in Kellogg's triangle, superiorly what do you have? See, superiorly here I have got cystic artery. This is cystic artery superiorly. Laterally what do I have? ये देखो, laterally I have got cystic duct, है ना. और medially what do I have? Medially I have got common hepatic duct. Very very clear, है ना. Superiorly cystic, laterally cystic duct, medially I have got common hepatic duct. So superiorly I have got cystic artery, laterally I have got cystic duct, and medially I have got common hepatic duct. Okay? Why do you need these triangles is that during cholecystectomy, laparoscopic cholecystectomy है ना, जब gall bladder निकाल देते हैं, that time to ligate the cystic artery, you enter into this foramen and ligate that artery. Okay? So very carefully you see about, you look even about the right hepatic artery also, so that you don't injure that. Right? So all of you understood these two borders, guys? Everyone understood these two borders? Be fast. Yes, I need a reply from you. Be fast, be fast, be fast. Very good. So the next important topic we shall be discussing is the celiac trunk. Okay? So celiac trunk, superior mesenteric artery, inferior mesenteric artery, these are the golden topics from every year. One question is definitely asked. Okay, so we shall discuss the branches, don't worry about that. But one very important thing you need to know before that is celiac trunk starts at, okay, celiac trunk is present at T12 vertebra. Celiac trunk, the topography is at T12. Superior mesenteric artery topography is at L1 and inferior mesenteric artery is at L3. Okay, now what are the branches of celiac trunk? Now all of you pay attention. The branches of celiac trunk are, the first branch is it supplies to the lesser curvature of the stomach like this. Now this branch which is supplying to the lesser curvature of the stomach is called as left gastric artery. I'm writing it as LGA, left gastric artery. Next, there is another branch that is going all the way like this, being very tortuous behind the stomach and finally supplying to your spleen. This branch is called as splenic artery. This is called as splenic artery. ठीक है? अब ये splenic artery क्या होगा? This splenic artery will divide into two branches. This splenic artery will divide into two branches. Now one branch is this. This is the second branch. Now this branch is called as short gastric artery. Short gastric artery. And the next branch is called as left gastro-omental artery. Right? Don't worry about the this thing, the abbreviations. I have written all the artery names clearly down. Okay, short gastric artery and left gastro-omental artery. Okay, let us leave this thing here. Next important thing is there is one branch that is coming all the way like this. This branch is called as hepatic artery proper. HAP, hepatic artery proper. This hepatic artery proper divides into two branches. One branch is called as common hepatic artery, and the other branch that comes down all the way like this. Okay, and this branch is between the stomach, right, as well as the duodenum. So you call it as gastroduodenal artery. This is called as gastroduodenal artery. And this common hepatic artery, all of you know, will further divide into two branches. One is called right hepatic artery, another one is called as left hepatic artery. Okay, so this gastroduodenal artery, listen very carefully guys, don't lose your attention. This gastroduodenal artery gives a branch like this which goes and anastomoses with left gastromental artery. What artery anastomoses? Which artery anastomoses with left gastromental artery? Right gastromental artery will anastomose with left gastromental artery. Right gastromental artery. Okay. Next, what did I tell you? I told you that at the level of L1, you have got superior mesenteric artery. So down here at the level of L1, you have got an artery called superior mesenteric artery. Okay. From superior mesenteric artery, you see a branch that is going up, right? This branch here is called as inferior pancreatoduodenal artery. When there is inferior pancreatoduodenal, there should be superior pancreatoduodenal. So this gastroduodenal artery is dividing into two branches. One you know already, and the next branch here is superior pancreatoduodenal artery. Superior pancreatoduodenal artery. So this is the complete blood supply of your stomach, liver as well as the spleen. Okay? All of you understood this, and I have written all the details here. Just have a look for a minute guys. All of you just go through this. All of you just go through this. All of you go through this. Right. So, Shams is asking, where does the right gastric artery arise from? Shams, right gastric artery comes from the hepatic artery proper. Okay? From the hepatic artery proper, the right gastric artery comes and anastomoses with the left. So, this is right gastric artery. Okay, Shams? Right. Now, after this, the next important thing which you need to know is that this ligament which you can see here, this is called as median arcuate ligament. Okay? A median arcuate ligament is a ligament of your diaphragm. Okay? You have got median arcuate and lateral arcuate in the diaphragm. I'll teach you now. So what will happen is that sometimes this medial arcuate ligament can compress the celiac trunk. Okay? Yes, Kunal Shastri. Kunal Shastri, this is more than enough, and good morning. So this median arcuate ligament, right? This median arcuate ligament will compress your celiac trunk. When it will compress your celiac trunk, that syndrome you call it as celiac trunk compression syndrome. So the only question they will ask you is, what is compressing? That is median arcuate ligament. Okay, right. Shams, yes, right gastric artery, I just told you here. Right gastric artery arises from hepatic artery proper. Right. Second important thing here is that let us discuss about superior mesenteric artery. So superior mesenteric artery starts from L1, I told you, है ना? So let us say this is the superior mesenteric artery. What are the branches and what are the branches of inferior mesenteric artery? Very, very, very simple branches. Just follow whatever I'm telling you. The first branch goes all the way down like this, right? First branch goes all the way down and makes a turn like this, है ना? अभी इस branch का नाम है, what is the name of this branch? This branch is called as ileocolic artery. So let us name it as branch A, and branch A is ileocolic artery. Branch A is ileocolic artery. Okay, so one branch of ileocholic artery comes like this and winds up around your appendix, and this is called as appendicular artery. Appendicular artery, which supplies your appendix. So in case of appendectomy, which artery will you clamp? Ileocholic artery. Okay, ileocholic artery you will clamp. Second important thing is that there is a branch that is coming all the way to the right side of the colon, right? And by the way, all of you know that this is ascending colon, this is transverse colon, this is descending colon. Ascending colon is on the right, so this branch which is supplying onto the right is called as right colon, right? If there is a branch that is supplying to the middle, this is called as middle colon. So I should call artery number B as right colic artery, artery number C as middle colic artery. Okay, what are the three branches of superior mesenteric? One is called as ileocholic, right colic, as well as middle colic artery. Okay, ये देखो, right colic, middle colic, and ileocholic artery. And I told you one thing, that from the superior mesenteric artery, there is a branch that is going up like this, and this is called inferior pancreatoduodenal. Yes or no? So don't forget that branch over here. Okay, so inferior pancreatoduodenal is also supplying. I hope all of you understood the superior mesenteric artery side. Now let us go on to the inferior mesenteric artery. Inferior mesenteric artery branches. The first branch goes all the way down and supplies to your sigmoid colon, right? This branch is called as sigmoid artery. What is this branch called? Sigmoid artery. The second branch goes all the way like this and supplies to your descending colon. This is called as left colic artery. क्यों? क्योंकि descending colon is on the left. So this is called as left colic artery. And the third branch comes all the way and supplies to the top surface of the rectum. So you call it as superior rectal artery. So what are the three branches here? Three branches are left colic artery, sigmoid artery, and superior rectal artery. So what did I write here? Left colic artery, sigmoid artery, and superior rectal artery are the three branches here. Okay, right. Now one very small important clinical thing you need to know, that there is a joining between both of them like this. The superior mesenteric artery branches, inferior mesenteric artery branches, दोनों यहाँ पे मिलेंगे, okay, and they form an arch like this, okay. So this union, this arch is called as arc of Riolan. Arc of Riolan. Okay. Yes, Shams. Yeah. Even superior mesenteric artery also gives branches to your jejunum as well as ileum, but they are not that important over here. The main branches are these for your exam point of view. Okay. Okay. Janashri. Yes, it is coming from the ileocholic artery. Okay. So this arc is called as arc of Riolan. And second important thing, you see this region where the sigmoid is supplied by sigmoidal artery, this point is called as Griffith point. This point is this point is called as Sudex point. Okay, this point is called as Sudex point. So why this point is very important is that this is the area that is more prone to a condition called ischemic colitis. Ischemic colitis, more prone to ischemic colitis. So I hope all of you are clear with the things which we discussed now. Okay, so these are all the explanation regarding the abdominal, regarding the celiac trunk, superior and inferior mesenteric artery. Okay, so these are the branches. Now, apart from this, you should know this another important topic, that is, when does the testis descend down? At which week, at which location the testis is present? So this is one of the most important thing. Okay. For example, all of you know that before entering into the scrotal sac, testis descends down from the abdominal region, right? From the abdominal region, the testis descends down all the way into the scrotal sac. This thing all of you know, right? So all of you tell me that at which week is the testis in the abdominal region? Anyone? At which week is the testis is located in the abdominal region? Kunal Shastri, Shams, Rini Atkinson, Osama, you're active. Only Osama, Rini Atkinson, right? Anand Prakash, Shams, only these are answering. What about the remaining doctors? So no, this very good Osama at 7th week. Okay, very good. So usually at 7th week, or you can also call it as second month. Okay, during 2 months or the 7th week, during that period, right, you would see what? You would see the testis that is located in the abdominal region. From the abdominal region to the inguinal region, right? When will the testis descend down till the inguinal region? Very good, Kunal Shastri. When will the testis descend down to the inguinal region? It will descend down at 3rd month. Okay? So, 3rd month where it is in the inguinal region. अब ये देखो, all of you know this is inguinal canal. When will it enter into the inguinal canal? 3rd month it will stay there, 4th month it will stay there, 5th month it will stay there, 6th month it will stay there, and once the 7th month hits, right, the testis descends down into the inguinal region. Clear? It descends down into the inguinal region. Now, within the inguinal region, from one end, it has to pass to another end. Yes or no? So, how much time will the testis take from one end to pass to another end? It would take around 3 to 7 days. Okay, it would take around 3 to 7 days to pass. And finally, the testis is back within your scrotal sac by 9 months. Okay, by 9 months, it is back into the scrotal sac. So, all of you are clear with this? Yeah, very good, Osama Sheikh. This green color thing is called as a gubernaculum. Gubernaculum. Right. So this is one very important topic, guys, that at which every question, everything, every point here can be an MCQ. Very, very important. The second important thing is abdominal wall layers. I hope all of you are perfect with this topic, right? So abdomen में अलग सा layers है. Abdomen continues down into the testis. Yes or no? There will be different layers. So what are these layers? We will compare and talk. So all of you just look here. Let us say in the abdomen you have got skin. ठीक है? Skin के नीचे क्या होगा? What will be beneath your skin? What will be beneath your skin? You have got superficial layer. You have got superficial layer. इस superficial layer में you have got two fascia. क्या है वो fascia? One is called as camper fascia and the other one is called as Carpal fascia. Camper fascia and Carpal fascia. Fascia के नीचे क्या होगा? Always and always remember, below the fascia what do you have? You have got muscle. What is that? External oblique muscle. Okay. After external oblique you have got internal oblique muscle. Okay. After internal oblique muscle, what do you have? Everyone, what do you have after internal oblique muscle? You have got transverse abdominalis. Transverse abdominalis. After transverse abdominalis, to cover this transverse abdominal, you need a fascia, and that is called as Janasri. Very good. Transverse fascia. Transverse fascia. Very good. Very good. Very good. Okay. Next important thing. And after that, obviously, you got your parietal peritoneum, uske baad visceral peritoneum, right? Parietal peritoneum. All of you concentrate here. Parietal peritoneum you have got. Okay. Now let us see these layers how are in continuation with the scrotal sac, right? So if you go down into the testis, the skin is nothing but the skin of scrotum. Skin of scrotum. After the skin of scrotum, the camper fascia as well as Carpal fascia together they form a muscle called as. Yes. Very good, very good, very good, very good. Dartus muscle. Dartus muscle. External oblique muscle is continuing as external spermatic fascia. External spermatic fascia. Okay. Next, internal oblique muscle is continuing as cremastric fascia. Cremastric fascia. Cremastric fascia. Okay. Next important thing is transverse fascia is continuing as internal spermatic fascia. This is not continuing as anything. Internal spermatic fascia. Internal spermatic fascia. And finally, the parietal peritoneum is continuing as tunica vaginalis. So there is no direct continuation, but it looks as a dotted lines. Okay, there are some interruptions in between, but anyways, that layer is a continuation of tunica vaginalis. Okay, tunica vaginalis. So all of you understood this? हाँ कि नहीं? Yes or no? Yeah? Right. Now, very good, Aman. Now, the next important topic we shall be discussing is the stomach bed. Stomach bed is very good, Kunal. Very good. Stomach bed is another very important topic which is being asked. Okay. So, in this picture, there is nothing you need to confuse here. Very easy picture. Just follow whatever I am telling here. Left side पे क्या है? Kidney होगा. Kidney के ऊपर क्या होगा? Left suprarenal gland. है ना? उसके पीछे you have got what? You have got this spleen. है ना? अभी look at this one. This is your pancreas. All of you know, right? This is your pancreas. And pancreas के ऊपर बिल्कुल there is one artery that is coming from the celiac trunk supplying to the spleen. I told you that is your splenic artery. है ना? That is your splenic artery. Now, apart from that, what you can see here? You see this ligament over here? This is a diaphragm actually. This is a projection of your diaphragm. उसके बाद, do you see there is some connection between the transverse colon? You know, these green color lines are nothing but called as transverse mesocolon. Okay? Transverse mesocolon. So transverse mesocolon is nothing but it is just a fold of peritoneum. Okay? एक fold है, peritoneal fold है, and this peritoneal fold attaches the transverse colon to the posterior abdominal wall. Okay? That is called as transverse mesocolon. So all of you know these structures are present. है ना? Now where is the stomach located? Stomach bed मतलब क्या? Stomach के नीचे जो भी structure है, all these are called as stomach bed. है ना? Now let us see where is the stomach located. Now all of you just look at the picture which I'm drawing. All of you pay attention here. So this is your esophagus, let us say. Okay. See, this is your stomach all the way down like this. This is your stomach. So all the structures which you can see behind the stomach are called as stomach bed. Sir, it is very difficult for us to remember the diagram and all. So it is very easy way, right? In Vishram Singh book, there is a mnemonic that is given. That is, Dr. S3 kills patients mercilessly. Okay, don't be like a Dr. S3. Okay. So what does doctor stand for? D stands for diaphragm. D stands for diaphragm. Okay. Next here S3. What are the three S which you see here? One is left suprarenal gland. One is left suprarenal gland. Okay. Another one is splenic artery. Another one is very good, Aman. Another one is splenic artery. और दूसरा कौन सा होगा? Splenic flexure. Splenic flexure. अब ये splenic flexure क्या है? ये देखो. All of you look here. This is called as hepatic flexure. और ये जो है ना, this is called as splenic flexure. Okay. So splenic flexure. So Dr. S3 kills. K stands for kidney. What kidney? Left or right kidney? Left kidney. So that is your left kidney. So he kills the patients. Okay? What does patient stands for? Pancreas. Patient stands for pancreas. And finally, M stands for transverse mesocolon. Transverse mesocolon. So these are the structures which are located under the stomach bed. So all of you understood easy, guys? Is it easy? Is this easy? Yes or no? Right. I already told you, your response is my encouragement. No other encouragement other than that. Right. So the next important topic we shall be discussing is relations of kidneys. So we shall discuss anterior relations of kidneys, posterior relations of kidneys. Okay. So what are the anterior relations and what are the posterior relations of kidney? So how many kidneys we have got? Two kidneys we have got. So in this we will discuss right kidney, left kidney, anterior relation, posterior relation of both the kidneys. ठीक है? You will tell me kidney के पास क्या चीज है? What are the things that are located near the kidney? First thing I will tell you, you will tell me just yes or no. First thing, suprarenal gland is there or no? Yes. Second thing, liver is associated with the kidney. Yes. Third important thing I told you, here you will have hepatic flexure, here you will have splenic flexure. ये देखो, hepatic flexure is also related with the kidney. Fourth important thing is duodenum. Can anyone tell me which part of the duodenum? See, this is the first part of the duodenum, this is the second part of the duodenum, this is the third part of the duodenum. So second part of the duodenum is related with the right kidney. Just by looking at the picture itself, it is very easy to answer that you have got first thing hepatic flexure of colon. Second important thing is liver. Third important thing is second part of duodenum. ठीक है. और 14 राइट एड्रिनल ग्लैंड. राइट किडनी के ऊपर लेफ्ट नहीं होगा ना. राइट एड्रिनल ग्लैंड इज देयर. राइट एड्रिनल ग्लैंड. Thank you, Shams. Thank you so much. Right adrenal gland. So these are the things. Now look at the left kidney. Okay? Look at the left kidney. In the left kidney, this is the left. In the left kidney also you have got hepatic flexure or splenic flexure this time. Is bar hoga splenic flexure. Okay? So this is your splenic flexure. Okay? After splenic flexure, you have got adrenal gland, left adrenal gland. After left adrenal gland, you have got the spleen, right? Not only spleen, you have got the body of the pancreas. If you very closely look here, you see the pancreas here. ये देखो, this is all the pancreas, right? So these are the structures that are located on related with the left side of the kidney. So by looking at the diagram itself, what are the structures? यहाँ पे hepatic flexure होगा तो यहाँ पे splenic flexure होगा. Splenic flexure. If there is right adrenal gland, यहाँ पे left adrenal gland होगा. Left adrenal gland होगा, है ना? And second and third important thing, we have got body of pancreas. Don't put it as tail. It is body of pancreas. Okay. And finally, we have got spleen, that is inferior surface of spleen. Inferior surface of spleen. These are the structures that are located in the anterior relation of right as well as left kidney. All of you are clear? Before I go to the second part, that is the posterior relations. यहाँ तक सब clear है ना? Everyone is clear, right? Very good, very good, very good, very good. Chalo. Now we shall discuss about the posterior relations. Posterior matlab पीछे है ना? Posterior relations. Now in the posterior relations, you see this green color line which I have drawn. This green color line is nothing but called as ligaments. What ligaments? Arcuate ligaments. ये देखो, this is called as medial arcuate ligament. and this is called as lateral arcuate ligament. Okay, medial as well as lateral arcuate ligament. Next important thing is this yellow color. Okay, let me shade this area. So you see this part here on both the sides, you know, this part which I have drawn on the both the sides, these horizontal lines which I am drawing, this is the muscle called as psoas major muscle. This muscle here is called as psoas major muscle. Psoas major muscle. Exactly psoas major muscle ke side. On the side of psoas major, here you have got an impression of another muscle like this. Okay, you see an impression of another muscle, and this muscle over here is called as quadratus lumborum. Very good. This muscle over here is called as quadratus lumborum. Quadratus lumborum. Okay, and finally you have got another muscle over here all the way, right? Now this muscle is called as transverse abdominis. This muscle over here is called as transverse abdominis, right? So we have got quadratus lumborum, psoas major, transverse abdominis. The same things on the other side as well. Okay? This thing everyone will remember, but the very important thing you have to remember is that you see a nerve, a artery, a vein that is coming down here. Okay? So all of you pay attention now. You see a vein that is coming like this. Okay? Vein के साथ साथ क्या आ रहा है? You see an artery that is coming like this. Not only that, you also see a nerve that is coming like this. Okay, so this vein, artery as well as nerve, this vein, artery as well as nerve together are the bundles of subcostal one. So these are subcostal vein, subcostal artery and subcostal nerve. Okay, apart from that, just two other nerves that are coming. Apart from that. What are these two other nerves are? ये देखो, ये एक nerve है. This is one nerve like this, right? And this is another nerve like this. Let us name this nerve as A, this nerve as B. Okay? A is called as iliohypogastric nerve, and B is called as ilioinguinal nerve. Ilioinguinal nerve. Okay, so the picture looks a little bit messy, but look at this table. This is the final table which you have to remember. Okay, what are the muscles? Diaphragm क्यों लिखा? क्योंकि मैंने बोला medial arcuate, lateral arcuate, they are parts of diaphragm. So diaphragm, psoas major, quadratus lumborum and transverse abdominis. Okay, and next coming to the nerves, subcostal nerves and vessels, right? Iliohypogastric, ilioinguinal. These are the posterior relations of both right as well as your left kidney. All of you understood? Everyone perfectly clear, guys? Everyone is perfectly clear? Right? Very good. Guys, now the topic in the neuro, whatever I'm discussing, you know, this I have prepared in such a way that this will also be useful for you in your physiology. It will be useful in your medicine also. Okay? Not only medicine, physiology, for anatomy as well. Okay? In these three subjects, these topics which I will be discussing right now from the neuro, this will cover up. Okay? Now, very important thing, you need to see these structures which I have drawn here. These are the structures of basal ganglia. Again, these are the structures of basal ganglia. Now, in this, fatafat, you will answer me what are these structures here. Abhi ye batao, what is this one? What is this structure here? This structure is called as, very good, this is called as thalamus. Okay? Thalamus के नीचे, anything below is called sub. So thalamus के नीचे जो है, this is called as subthalamic nuclei. Subthalamic nucleus. Subthalamic nucleus. ठीक है? Next, thalamus के ऊपर, whatever things are located above the thalamus, this is called as caudate nucleus. This is called as caudate nucleus, right? So, guys, all of you are with me, or you are stuck? I can't see yes, no, nothing I can see. All of you are with me, right? You're all with me, or so गए? Still there? Very good. What about the remaining? Shams, you are there? Shams, Sonia, everyone is here? Right. So I just felt for a minute that I am teaching to myself. Chalo. Anyways, so this is caudate nucleus. Yes, Aman, this PDF will be available. Na? So caudate nucleus. After this, you see this one is called as internal capsule. Internal capsule. Okay. After the internal capsule, after the internal capsule, you see this blue color one. This blue color thing is called as putamen. Putamen. Okay. And these two structures together you call it as globus pallidus. Globus pallidus. और ये smiley क्या है नीचे? Smiley. This smile is nothing but called as substantia nigra. Substantia nigra. Very good, Aman. Very good, very good, very good. Right. So, guys, they can give you a real picture and point at one thing and ask what is this. Okay, you have to remember क्योंकि image based questions are most commonly asked from this part. Okay, so caudate nucleus, internal capsule, putamen, globus pallidus, substantia nigra. चलो ठीक है, क्यों बताया हमको? The reason why I told you this is here caudate nucleus is very important, putamen is very important. Yeah, globus pallidus is very important, subthalamic nucleus is very important, and substantia nigra is very important. For example, if there is any kind of damage to caudate nucleus, this will lead to a condition called as chorea. All of you know what is chorea? This would lead to a condition called as chorea, right? So next important thing, if there is a damage to globus pallidus, this will lead to a condition called as ethetosis. This will lead to a condition called as ethetosis. In the same way, if there is a damage to the subthalamic nuclei, this will lead to a condition called as hemibellismus. Hemibellismus. And all of you know this thing. अगर substantia nigra में dopaminergic neurons की कमी, right? If there is a damage to or degeneration of dopaminergic neurons in substantia nigra, that would lead to Parkinson disease. That would lead to Parkinson disease, right? Now, what is chorea, guys? So chorea in the sense it is a hyperkinetic disorder. What are these limbs? Distal limbs. So patient will have this kind of movement like this, okay? Such kind of movement, irregular movement, which is happening involuntary without him knowing, right? Involuntary like this, these movements are called as chorea. Such movements are called as chorea, okay? After this, दूसरा क्या है? Globus pallidus. Globus pallidus, what is this? Even in globus pallidus, the ethiotosis component, even there also distal limbs are involved, but the movement is not fast like this. The movement is slow. Okay, these are called as slow breathing movements like this. Slow breathing movements. Sometimes breathing movements even happen for your head and neck also in this way, right? So these slow breathing movements involuntarily is called as ethiotosis. Hemibellismus. Hemi matlab kya? Half. So either hand and leg on one side only, right? Either one hand on one leg or completely both the upper limb one side and lower limb. So one hand, one leg, both of them involuntarily they will move. Here proximal muscles are involved. In previous both the distal muscles are involved. Here proximal muscles are involved. So involuntarily patient will do like this, okay? So these kind of actions even for the lower limb also. So never ever sit in front of him, okay? Or never ever drop anything in front of him. So these are the movements which you see. Clear all of you? So hope everyone is clear. So chorea is rapid movements. Okay, chorea is rapid involuntary movements of distal limbs. Distal limbs, ठीक है. When it comes to ethetosis, ethetosis क्या होगा? Ethetosis rapid नहीं है, they are slow breathing movements of distal limbs, ठीक है, of your distal limbs. Now when it comes to hemibellismus, usually proximal muscles are involved. Proximal muscles of both upper limb and lower limb are involved. But bilateral or unilateral? Unilateral, only onto one side. Okay, unilateral because only onto one side. So from here, definitely you can expect one question, guys. Definitely you can expect one question from this. The second question where you can expect is circle of Willis. Everyone is perfect. Circle of Willis. Okay. Now I will not only just draw the circle of Willis, I will relate the circle of Willis clinically, how it is asked in medicine as well as physiology. I will relate it. Okay. So in the circle of Willis, all of you know, that the branches here. Here we have got a branch like this. This one is called as your internal carotid artery. Internal carotid artery on both the sides. And a branch here which is going on other side. This is called as middle. What is this? Cerebral artery. This is called as middle cerebral artery. And what is this? Internal carotid artery. Internal carotid artery. And one branch is given anteriorly. ये branch कौन सा है? Very good, Osama. One branch which is given anteriorly, this is called anterior cerebral artery. So two branches यहाँ पे, middle cerebral artery, anterior cerebral artery. ठीक है? अभी ये दोनों anterior cerebral arteries जो है, both of them they join together with the help of anterior communicating artery. Okay? Anterior communicating artery. Clear? Anterior communicating artery. Second important thing is that let us say that here we have got an artery that is going up. This artery is called as vertebral artery. Right vertebral, left vertebral, है ना? Write it down. Right vertebral artery, and this is called as left vertebral artery. अभी ये देखो, both the vertebral arteries they join together. Right? Both the vertebral arteries they are joining together and they form what? Very good. They form a basilar artery. Okay? Now this basilar artery will divide into two branches like this. Okay? What are these two branches? These two branches are posterior cerebral artery. क्यों? क्योंकि यहाँ पे anterior cerebral artery is there, middle cerebral artery is there. Now we need posterior cerebral artery. Okay? Now the real clinical part is here. In this posterior cerebral artery, there are two parts. ये देखो, this one is called P1 part, है ना? This is called as P2 part of cerebral artery. P1 in the medial side, P2 part in the lateral side. ठीक है? उसके साथ there is one more branch. That is coming all the way like this. This is called as anterior inferior cerebellar artery, also called as AICA. Anterior inferior cerebellar artery. When anterior inferior cerebellar artery is there should be posterior inferior cerebellar artery also. So here posterior inferior cerebellar artery is coming out. This is pica. And one last branch I want to tell you, that from this vertebral artery you see two branches that are coming down and they are forming a single branch. This is called as anterior spinal artery. ये सामने anterior spinal artery है, पीछे posterior spinal artery will be there, right? So all of you look here now. Second important thing is that there is a connection between this carotid artery here all the way with the P2, right? So this connection you call it as posterior communicating artery. Posterior communicating artery. So this circle which you can see here, this is called as circle of Willis. So the only question which is all the time repeated is, which of the following artery do not participate in the circle of Willis? Batao, anyone know that which artery is not a part of circle of Willis? Very good, Aman. Very good. Middle cerebral artery is not of part of circle of Willis. Right. So guys, this thing everyone know. Circle of Willis, I know you have practiced some 10-20 times. So circle of Willis is always important before you go to the exam. Okay. But now whatever I'm telling you, don't write any notes. Just listen to whatever I'm telling you, because now I'm telling you the clinical part. Okay. So exactly look at the pictures where I'm drawing here. So here I'm drawing one structure like this, right? This is midbrain. Midbrain के बाद क्या होगा? This part which I'm drawing right now is your pons. Pons के नीचे here I have got another part. This part is called as medulla oblongata, and all the way down here I have got spinal cord. Okay, so let me shade these areas. Pons I'm shading it with the green. Okay, उसके बाद then I'll use light blue to shade the medulla oblongata. Okay, now just listen carefully. Just listen carefully to whatever I'm telling. Just look at the midbrain. M is midbrain. Hai? Let me write it down here. Midbrain. उसके बाद pons. उसके बाद medulla oblongata and spinal cord. Okay, all of you just concentrate on the midbrain, guys. Where is the midbrain located? Near which artery the midbrain is there? By looking at the picture you tell. Okay, I'll tell you one thing. Is it right or wrong? Tell. Midbrain is exactly located near PCA. More exactly to tell, it is located near the P1 component of PCA. Yes or no? Right? Only if you tell yes, I'll move forward. Yes or no? Because this part everyone has to understand. Very good. So can I tell that midbrain is supplied by P1 part of posterior cerebral artery? Okay, P1 part of posterior cerebral artery. Next, where is pons located? Pons is located exactly here. And what is this artery here? This artery is your basilar artery. This artery is your basilar artery. So pons is supplied by basilar artery. Basilar artery. Okay. Next, when it comes to medulla oblongata is present near which artery, guys? All of you see this entire length of this artery. The length of the artery is more. So I think this must be the artery which is supplying the medulla oblongata, and these are your vertebral arteries. Hai ki nahi? These are your vertebral arteries. So medulla oblongata is supplied by vertebral artery. Okay? और उसके बाद spinal cord. If you look at the spinal cord, anterior side of the spinal cord is supplied by anterior spinal artery. Spinal cord के पीछे posterior side is supplied by posterior spinal artery. So I should write it as anterior spinal artery and posterior spinal artery. Okay? So this blood supply is everyone here. Everyone is clear with this blood supply, guys? Everyone is clear, right? Now what I want you to do is that, guys, just concentrate on the point which I'm highlighting. Okay? Ye dekho, exactly this point I am highlighting here, this part. Okay? No, see, Jonas, just look where my midbrain is located. Midbrain is located near posterior cerebral artery, that to P1 part of posterior cerebral artery. So midbrain is supplied by P1 PCA. Pons is present at the level of basilar artery. So pons is given by basilar artery. Medulla oblongata is present at the level of vertebral arteries. So medulla oblongata is given by vertebral arteries. And spinal cord, what is the artery that is running to spinal cord? Anterior spinal artery. So I have write it as anterior spinal artery. But behind the spinal cord, posterior spinal artery will be there. So posterior spinal artery. Clear, Jonas? Right. Anyways, just concentrate at this region, guys. Now in this region, tell me which arteries are completely lateral, which arteries are completely medial. First tell me which arteries are located to the extreme, laterally located. Batao. Everyone. Which arteries are located to the extreme, laterally, complete laterally? Very good, very good, very good, Osama Sheikh. You see, pica is located completely laterally, you know, and anterior spinal artery is located completely medially. Yes or no? So, guys, everyone figured it out, by the way. Everyone understood, right? These arteries are located completely laterally, and these arteries are located completely in the center. Or only Osama Sheikh understood? Everyone understood? Aman, you understood. Rini Atkinson, you understood. Osama Sheikh, all of you understood, right? Right. So why am I telling you this is, you heard of two syndromes, lateral medullary syndrome, medial medullary syndrome. So in lateral medullary syndrome, arteries which are located laterally are involved. Medial medullary syndrome, arteries which are located medially will be involved. So यहाँ पे arteries which are laterally located are pica. So can I tell here that pica is responsible for causing lateral medullary syndrome? So occlusion of pica will cause lateral medullary syndrome. Occlusion of anterior spinal artery, because that is in the center, medial most, that will cause medial medullary syndrome. Medial medullary syndrome. So this is one of the very, 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 very important thing. I want you to keep it in your mind. Okay. So if you are perfect with this, I hope all of you understood this. Right? So these are the two important MCQs here. Pica and ICA, lateral medullary syndrome and medial medullary syndrome. Second important thing is that how the cranial nerves are distributed within your central nervous system. How the cranial nerves are distributed are, see, first important thing. In the midbrain, you have got cranial nerve number 3, you have got cranial nerve number 4. In the midbrain, you have got this. Uske baad, when it comes to the pons, in the pons, you have got cranial nerve number 6, right? And if you go little bit laterally, you have got cranial nerve number 7, cranial nerve number 8. So can I tell 6, 7, 8, all these three are located in the pons itself, right? When you come to the medulla oblongata, here you have got 9, 10, 11 and 12. 9, 10, 11 as well as 12. Okay? So then where is 5? 5 has got two nuclei. One is called as sensory nuclei, another one is called as motor nuclei. Ye dekho. 5 motor nucleus is located in the spons. This is 5M. Okay? 5 sensory nucleus is located all the way. 5 sensory nucleus is located all the way from midbrain, pons, medulla oblongata and spinal cord. Okay? At which level of spinal cord? It is located all the way till C1, C2 level of spinal cord. So the 5th sensory is the largest cranial nerve nuclei. Okay? It ranges all the way from the midbrain till the spinal cord C1 and C2 level. Okay? Now here, what are the clinical points? Can I tell you? The clinical points here are just concentrate on the midbrain, pons and medulla. What are the nuclei that are laterally located and what are the nuclei that are medially located? Nuclei that are medially located are 3, 4, 6 as well as 12. Right? These are the nuclei that are medially located. Nuclei that are laterally located are 7, 8, 9, 10 and 11. These are the nuclei that are laterally located. Okay. Now, when I talk about medial medullary syndrome, lateral medullary syndrome, I have to take into consideration of midbrain, pons or medulla. I should take into consideration of medulla. Ye dekho. Now look at the medulla. In the medulla, what are the nuclei that are laterally located? 9, 10 and 11. So can I tell in lateral medullary syndrome what cranial nerve nuclei are involved? 9, 10, 11 are involved, right? In lateral medullary syndrome, 9, 10, 11 are involved. Then now you will tell me, guys, in case of medial medullary syndrome, which cranial nerve is involved? Medial medullary syndrome, which cranial nerve is involved? Anyone? Yes, be fast. Very good, Rohan Bhatia, very good. So 12th cranial nerve is involved in medial medullary syndrome. So overall, I want to tell you that lateral medullary is because of pica, right? Pica, and 9, 10, 11 cranial nerves are involved. Okay? And medial medullary is because of anterior spinal artery and 12th cranial nerve is involved. So all of you understood this, guys? All of you understood this? Perfectly understood this? Clear? Everyone is clear, right? Rusty, you're clear? Very good. What about the others? Baki doctors. Very good, very good. Very good, very good, very good, very good. Right. So the next important thing is in the thorax. Okay. I know that there are many other topics which we have to cover in the neuroanat, head and neck and all, right? But right now in less time, how many important topics we could cover, I'll cover, right? And remember one thing, that till the end of your exam, every week there will be a live session regarding the images. The image based discussions I will do, syndromes I will do, triangles I will do, muscles I will do, right? Cadaveric images I will do. So number of multiple sessions we'll have. So I think all these sessions before your exam will be more than enough to score 15 plus marks in anatomy, and believe me and trust me. Okay, right. So but whatever I have started from today onwards, if you follow till the end 10 days before your exam, so that would be more than enough for your anatomy, right? So in the thorax, the only important thing which you need to know is regarding the diaphragm and some of the openings and all. Okay, so regarding this diaphragm, all of you know this is the shape of the diaphragm, right? Now in this diaphragm itself, I have been telling you from the starting, there is something called medial arcuate, lateral arcuate, है ना? तो यही पे है वो. So first important thing is that you see two foramens here, है ना? These are called as foramens of Morgagni. Foramens of Morgagni. So what is the use of foramens of Morgagni? यहाँ से ना there is one vessels that are passing. These are called superior epigastric vessels. Okay, superior epigastric vessels, they pass from this foramen Morgagni. Next important thing is you see a tendon here. This is called as the central tendon of diaphragm. Central tendon of diaphragm. Okay. Next important thing is you see these two structures where I have written L3 and L2. है ना? This is called as the right crus of diaphragm. है ना? और ये जो है ना, this is called as the left crus of diaphragm. If they ask you, right crus of diaphragm is at the level of L3, left crus of diaphragm is at the level of L2. ठीक है, ये क्रस के पास है ना, near the crus you see two elevations like this, two bumpy elevations here. So what are these two bumpy elevations? So all of you now look here. ये देखो, this one over here is called as arcuate ligament. What arcuate? Median arcuate ligament. Okay, this is called as medial arcuate ligament. And ये वाला कौन सा है? This is called as lateral arcuate ligament. So one is called medial arcuate ligament, another one is called as lateral arcuate ligament. Okay, so this is the general anatomy which you need to know. Second important thing is how medial arcuate ligament is formed. All of you know that there is a muscle, है ना? The name of the muscle is psoas major, right? We discussed when we were discussing in the posterior relations of kidneys, if you remember, psoas major करके एक muscle है. So every muscle will have fascia, and that fascia of psoas muscle, when it becomes thick, that will form the median arcuate ligament. Okay, so median arcuate ligament is formed by the thickening of fascia of psoas major. Psoas major. Okay, next important thing is then how is lateral arcuate ligament formed? Lateral arcuate ligament is formed just side to psoas major. In the posterior relations we discussed quadratus lumborum, याद है? Same to same, quadratus lumborum के एक fascia होगा. So thickness of fascia of quadratus lumborum. Quadratus lumborum. Hi Migendra Kumar, hello, how are you? Quadratus lumborum. So what passes through foramen morgagni? I have already told you, superior epigastric vessel pass through foramen morgagni. And next important thing you need to remember here is that what is the nerve innervation? So there are some motor nerves that are innervating here. They are C3, C4, C5. Keep the diaphragm alive. Okay, C3, C4, C5. They are the motor innervation to your diaphragm. So remember like that. Even in the book called Vishram Singh, it is given like this, that C3, C4, C5, keep the diaphragm alive, right? Fine. The most important part which you need to know in diaphragm is the openings. All of you know that there are diaphragm openings, right? So one best mnemonic, I'll give it to you. Just remember that. Very good, Rini Atkinson. They are superior epigastric. Very good, very good. Yeah, C3, C4, C5 are the root values of the phrenic nerve. Okay, right. So coming to diaphragm opening, one very good mnemonic is that I ate 10 eggs at 12 o'clock, है ना? रात 12 बजे को मैंने 10 अंडा खाया, right? I ate 10 eggs at night 12 o'clock or afternoon 12, जो भी है ना? I ate. What is I ate? I ate मतलब I stands for inferior vena cava. Inferior vena cava, which is also called as vena caval opening, है ना? Vena caval opening. So vena caval opening, what is passing through this vena caval opening? Inferior vena cava. So it is at the level of 8. What 8? T8, not C8. Okay? It is at the level of T8. I ate 10 eggs, है ना? 10 EGGS. What does EG stands for? EG stands for esophagus. ठीक है, ईसोफेगस के बाद ईसोफेगस को ईसोवेगस भी बोल सकते हैं, है ना? सो वेगस right as well as the left trunks of vagus, it means the complete vagus, है ना? So they are passing through what? T10. They are passing through T10. So I ate 10 eggs at 12 o'clock. At 12 o'clock. At 12 o'clock. What does A stands for? A stands for azygous vein. Okay. A also stands for aorta. A के बाद क्या है? T. T stands for thoracic duct. Thoracic duct. So all of them are passing through T12. All of them are passing through T12. Very good, Rini Atkinson. Very good. So these are the at the end points which you need to understand here. Okay. So what are the structures that are passing to T8, T10 and T12? These are the things. Now this part which I have told you is as per the mnemonic. But there are some two extra structures which are passing here. They are not included in the mnemonic. What are those two extra structures are? At the level of T8, even right phrenic nerve is also passing. Right phrenic nerve is also passing. Just remember it like that. Okay. उसके बाद at the level of T10, yeah, at the level of T10, esophageal branches of left gastric artery are also passing. Esophageal branches of left gastric artery are also passing through T10. Clear all of you? Chesart, yes, it will be uploaded. Don't worry about that. But I want you to be in the live session so that if you ask any doubts, I'll clarify it, okay? So all of you understood regarding the diaphragm. There is nothing to understand. This is all direct points which you need to know. No concepts here, right? So after this, the next important is intercostal space. Okay? Intercostal space. Intercostal space matlab kya? Between two vertebrae, between two ribs, whatever space you have, that is called as intercostal space. Okay? So between two ribs, the space you called as intercostal space. So in this intercostal space, what are the structures that are located? First of all, let us see this. This muscle which you can see here, this muscle which you can see here is outside. So when it is outside, I should call it as external. So this is called external intercostal muscle. External intercostal muscle. Uske baad, after external intercostal muscle, next you have got this muscle over here. This is called as internal intercostal muscle. Internal intercostal muscle. And innermost, that intercostal muscle is called innermost intercostal muscle. Innermost intercostal muscle. Innermost intercostal muscle. Right? Innermost intercostal muscle. So we have got external intercostal, internal intercostal, and innermost intercostal. Also you called as intercostal intima. Okay? But just remember it as internal intercostal. Now, on the top surface, right, in the intercostal space, you have got three things. One is you have got a vein. Okay? Vein के नीचे क्या होगा? Artery होगा. Artery के नीचे क्या होगा? Nerve होगा. So you have got three things over here. You have got three things over here. What are these three? You have got a vein. After that, you have got an artery, intercostal vein, intercostal artery, and intercostal nerve. So what is a mnemonic? VAN. Okay. So this VAN is applicable for all intercostal spaces except first intercostal space. Okay. In the first intercostal space, you have got first nerve, uske baad artery, uske baad vein. Okay. But in the first intercostal space, you have got nerve, artery, and then vein. So this is vein, artery, and nerve. That is artery, nerve, and vein. So till here, all of you understood. Felicia, very good. Osama, very good. Right? Now, the reason why am I telling you about this intercostal space is that, guys, whenever you are giving thoracocentesis or a pleural taps, right? If a patient is having excess amount of fluid in his lungs, in case of, let us say, pleural effusion and all, you need to remove the fluid. So when you need to remove the fluid, you need to do a tapping. So what you do is that, these are the two ribs, for example. Okay, never ever put the needle along the inferior surface of the rib. Okay, why? Because along the inferior surface of the rib, you have got a vein, artery, and nerve. Always put the needle above the superior edge of the rib. Okay, so above the superior edge of the rib, matlab yahan pe exactly you can put the needle here. Clear? So this is a perfect location for pleural tap. Pleural tap. Now, after this, there is one question that is asked in a order. In pleural tap, what are the layers you are crossing and going? Okay. So what are the layers you are crossing? First layer you cross is skin. Okay. Skin ke baad next you cross fascia. After the fascia, the next one you cross is serratus anterior. Sir, why serratus anterior? Because you are doing a pleural tap here. Here you have serratus anterior muscle. After serratus anterior muscle, you have got this external intercostal muscle. External intercostal muscle. External intercostal muscle के बाद कौन सा होगा? Internal intercostal muscle. Internal intercostal muscle. After internal intercostal, you come across innermost intercostal. That is innermost intercostal muscle. After innermost intercostal muscle, you have got this green color layer, hai na? This green color layer is called as endothoracic fascia. This green color layer is called endothoracic fascia. Okay. So next you come across this green color layer called as endothoracic fascia. After endothoracic fascia, the next layer here, after the green, this blue color layer is called as parietal pleura. Parietal pleura ke baad hi fluid hoga, you will take it out. Okay. Then you have got parietal pleura. Parietal pleura. So all of you understood this? Yes or no? Everyone perfectly understood this, guys? Are you all understanding whatever I'm telling you? Right? You're all understanding perfectly clearly, right? No confusion, right? Everyone? Anna? All of you understanding, right? Very good. Very good. Now, another important topic in the thorax that is asked is regarding the formation of the azygous as well as hemiazygous vein. So, very simple picture I'm going to draw here, guys. Just focus on the picture which I'm drawing. Very simple picture. Okay. Now, all of you look here. First important thing, what I will draw is, I will draw a Y. So, this is a Y shape. Okay. In this Y shape, this is called internal jugular vein. This is also called internal jugular vein. Okay. And after that, this part over here, you see, this is called as right brachiocephalic vein. Right brachiocephalic vein. Okay. So when that is right, then this will become what? Left brachiocephalic vein. Okay. Now, just draw three lines. Only draw three lines. What are those three lines? Put a line all the way from here like this. Okay. And put one line like this top and put one line like this bottom. Okay. So this straight line which I have drawn, this is called as azygous vein. Okay. And this one is called as accessory hemiazygous vein, and this is called as hemiazygous vein. That's it. Okay. So very simple picture, but the important thing is that you should know what veins are draining into this. The veins which are draining into this azygous hemiazygous system are called as PIV, posterior intercostal veins. So where are they draining, we should see. Okay. So first vein, right? Always remember, the first vein drains into the right brachiocephalic vein. The first one on the right will drain into the right brachiocephalic vein. In the same way, the first one on the left also will drain into left brachiocephalic vein. Finish. Now one is done. One is done. Now coming to the second one. On the azygous vein, you have got a vein like this. Okay. In the same way, on the left brachiocephalic also, you have got a vein like this. Now, what are these two veins? This vein is called as right superior intercostal vein. Right superior intercostal vein. And this is called as left superior intercostal vein. Right superior intercostal vein, left superior intercostal vein. Okay, so what are you trying to tell me? What am I trying to tell you is that posterior intercostal vein number 2, number 3, number 4, all of them together they drain into right superior intercostal vein. Posterior intercostal vein number 2, number 3, number 4 on the left side, all of them together they drain into left superior intercostal vein. So till here also you are clear, right? After 4, we have got 5. So 5, 6, 7, 8, 9, 10, 11, 12. So from 5 till 11, they drain into this azygous vein. Okay. So from 5 till 8, they drain into accessory. Again, from 9 till 11, they drain into hemiazygous. That's it. These are the veins which you need to know. So all of you guys, is it easy? Yes or no? Very good. Very good. Very good. Now, this is the explanation which I have already given. This is the explanation which I have already given here, guys. Aman, this is the explanation which I have already given. So the first one draining into right brachiocephalic, right? Second, third, and fourth draining into right superior intercostal, intern into esophagus here. 2, 3, 4 drains first into right superior intercostal, then drain into esophagus. Okay. 5 to 11 drain into again esophagus. On the left side, 5 to 8 drain into accessory, 9 to 11 drain into hemiesophagus, right? If you look at the picture, you will understand here, okay? Nothing to worry. Look at the picture, you will understand. Now, the next important topic is root of the lung, right? So, these are the lungs from the anterior side. For example, if I am turning the lungs like this part which you see is the root. So, this is the part, okay? Now, in the root of the lung, there is nothing much to discuss, guys. Very, very easy. First important thing is lungs have pulmonary artery, yes or no? Here they go. This is called right pulmonary artery. This is called as left pulmonary artery. So let me write it down. This is called as right pulmonary artery, or this is called as left pulmonary artery. Okay. And you know, lungs have got bronchi. Yes or no? So bronchus is also present. But here, if the bronchus is present above the pulmonary artery, you call epi. If the bronchus is present below the pulmonary artery, you call it as hypo. So here you have got a bronchus. Here also you have got a bronchus. So bronchus on the top, this is called as epiarterial bronchus. Eparterial bronchus. Eparterial bronchus. Okay. And this one is called as hyparterial bronchus or hiparterial bronchus. Hiparterial bronchus. Clear? So, coming on to the bronchus here. Here we have got only one thing. This is called as left principal bronchus. Only one thing is there. So, only one name. Left principal bronchus. Left principal bronchus. ठीक है? Bronchi के अंदर bronchial artery होगा कि नहीं? There is bronchial artery in the bronchi. Yes or no? See, the right one is having let me use another color. The right one is having only one bronchial artery, but whereas the left one is having two bronchial arteries. So these are your bronchial arteries. These are your bronchial arteries. Okay. And within the lungs, do you have veins or no? Pulmonary veins are there. है ना? So on the right side, I have got superior pulmonary vein. नीचे जो है inferior pulmonary vein. यहाँ पे भी superior pulmonary vein and down we have got is inferior pulmonary vein. So these are superior as well as inferior pulmonary veins. Superior as well as inferior pulmonary veins. All of you understood this, guys? I don't think so. This is very difficult for you to understand. This is very, 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 very easy. Okay. Right. The next important topic which we shall be discussing now is the blood supply of the heart. Now, I will not only discuss the blood supply, I will also discuss some parts related with the medicine also. So that will be useful for you there also. Okay. So here, this artery which I have drawn here is called as the right coronary artery, and this one is called as the left coronary artery. Okay. Now listen very carefully to whatever I am telling. So from the right coronary artery, you have got a branch that is coming down all the way. You know, this is your right coronary artery and it passes on to the back like this. Okay. Second important thing, from this a left coronary artery is coming down. Left coronary artery is having three branches. Okay. एक branch जो है ना, this will go on to the back, make a circle like this, and anastomosis with the right coronary artery. So this is called as circumflex artery. Circumflex artery. This is left coronary artery. This is right coronary artery. Clear? Second branch comes all the way down to the anterior side. ये देखो, ये anterior surface of heart है. So this is an anterior artery which is descending down. So descending artery. So this artery is also called as left anterior descending artery. Okay, left anterior descending artery. So this left anterior descending artery goes on to the back posteriorly like this and waits for an anastomosis. So this artery which you can see here is LAD, left LAD, left anterior descending artery, or anterior, very good, Osama, interventricular artery, anterior interventricular artery, simply called as AIVA, anterior interventricular artery. Okay. Now the real thing begins. What is the real thing is that from the right coronary artery, you see a blood vessel that is coming in pink. You know? So this artery is called as posterior interventricular artery, PIVA, posterior interventricular artery. अब question ये है कि in some of the individuals, posterior, in this picture, posterior interventricular artery is coming from right coronary artery. Yes or no? If the posterior interventricular artery is coming from right coronary artery, this heart is called to be right heart dominance, right cardiac dominance. If the posterior interventricular artery is coming from circumflex artery, this is called to be left heart dominance. If the posterior interventricular artery is coming from both right and circumflex artery, this is called as codominance. Clear all of you? This is called as codominance. So these are the important branches which you need to know. Apart from this, the next important branches are from right coronary artery, you see a branch that is coming like this. You know? This branch is called as right marginal artery. Right marginal artery. So right marginal artery hoga, to left marginal artery bhi hoga. From circumflex, you see a branch that is coming down. This is called as left marginal artery. एक है right marginal artery और दूसरा है left marginal artery. Clear? Now we have got SA node and AV node. Agree? ये देखो यहां पे होगा SA node, right? And here you have got AV node. Let us say this is SA node and here you have got AV node. Even SA and AV node also need blood supply. So from where the blood supply is coming? Look here now. For SA node, there is from right coronary artery itself, you get a branch like this. This is called as nodal branch. Okay. What is this called? Nodal artery or nodal branch. Nodal branch. This nodal branch is supplying what? SA node. Next important thing is that from posterior intercostal artery, ये देखो, from posterior interventricular artery, from posterior interventricular artery, you see a branch that is coming like this all the way backside and supplying to your AV node. This is called as first septal branch of posterior interventricular artery. This is called as first septal branch of PIVA, posterior interventricular artery. Right? So I hope till here all of you are clear, right? Till here all of you are clear. So let us write down the same things here. If PIVA is coming from right coronary artery, you call it as right cardiac dominance. Right cardiac dominance. This is called as left cardiac dominance and this is called as codominance. This is called as your codominance. Okay. And if you can see here, the same branches I have written. Right coronary artery main branches, ये तीन है. Left coronary artery का main branches, these three are the main branches of left coronary artery. You know one thing guys, if these coronary arteries are occluded, है ना, तो क्या होगा? Patient will have myocardial infarction. So what are the three most common coronary arteries? What are the three most common arteries of the heart that are occluded? Are the first important thing is anterior interventricular artery or left anterior descending artery. This is the first one. Second one is right coronary artery. Third one is circumflex artery. Circumflex artery. Most common ये है. Most common ये है. Second most common RCA and the circumflex artery as the least common one. ठीक है? Circumflex is the least common one. ठीक है? Now you told me this arterial blood supply. Okay? You told me this arterial blood supply. Okay? Now, second important thing is what kind of MI we will get. Guys, just don't mug it up. Picture देखो और समझो, ठीक है? All of you look at right coronary artery. right coronary artery is supplying the inferior surface. ये देखो, this is the inferior surface of the heart. है कि नहीं? This is very good. Rini Atkinson, you are very fast. Very good. Inferior surface. So can I tell right coronary artery will cause inferior wall MI? Inferior wall MI. है ना? उसके बाद left anterior descending. Left anterior descending is passing anterior to the heart. So it will cause anterior wall MI. Anterior wall MI. Circumflex artery कहाँ पे है? Circumflex artery is on the lateral side. है ना? It is passing laterally downward. Yes or no? So this would cause lateral wall MI. Lateral wall MI. And posterior interventricular artery is on the back. So it will cause posterior wall MI. Posterior wall MI. Posterior wall MI. Okay. So these are some of the important things which I want you to know. Okay. Now after this, the next important thing you need to know is constrictions of esophagus. What are the different types of constrictions of esophagus? You just need to know the numbering. So I will tell you the number, just mug it up, okay? 6460. Okay, I don't think so it is difficult to remember. 6460 is the number which you need to, 6460 is the number which you need to remember. Okay? So this is your esophagus all the way, and this is your stomach. This is your stomach, right? Now there is a constriction above here. This is called as cervical constriction. This constriction is called as cervical constriction. Okay. Next important constriction is you have got a constriction where there is an aorta here. You know? This is called as aortic constriction. This is called as aortic constriction. Okay? Aorta के बिल्कुल नीचे, just below the aorta, you have got bronchus. You have got a bronchus. So here also the esophagus will undergo constriction. So this constriction you call it as bronchial constriction. Bronchial constriction. And finally guys, I have just now spoke about the diaphragm, right? So diaphragm, all where the diaphragm opening is happening and from where the esophagus will pass, I think T10, I think, right? T10. So this is a diaphragmatic constriction. There also the esophagus will be constricted. Diaphragmatic constriction. And number कौन सा बोला था मैंने? I told you to remember 6460. 6 C6, 4 T4, again 6 T6, diaphragmatic 0. What 0? T10. Okay. So these are some of the constrictions which you definitely need to know. Clear all of you? Everyone is clear, guys? Everyone is clear, yes or no? So we shall discuss the last part now, that is the lower limb. In the lower limb, we shall focus on the most important topics over here. So Rini Atkinson, and one more thing I'm telling you guys, I know it is already 4 hours, but still you guys are with me and I'm really happy for that, and thank you so much for being with me this late night, you know, for believing in me and listening to my lectures, guys. Thank you so much. So here one very important thing you need to see in case of femoral triangle, है ना? Very important question, you know about the femoral triangle. First of all, we shall discuss about the borders of femoral triangle, then we shall discuss about the contents, and then we shall discuss about the floor of the femoral triangle. Okay? So first of all, regarding the borders of femoral triangle. So can anyone tell me what are the borders of femoral triangle? Yeah? So the base of the femoral triangle is formed by inguinal ligament. So if someone is asking you, inguinal ligament is ranging all the way from एंटीरियर सुपीरियर इलियाक स्पाइन टिल प्यूबिक ट्यूबरकल, यहाँ वहां से लेकर यहां तक है ना, जो भी है ना, दैट इज कॉल्ड एज इंग्वानल लिगामेंट. इंग्वानल लिगामेंट फॉर्म्स द बेस ऑफ द फेमोरल ट्रायंगल. After that, you have got a lateral border, you have got a medial border. So lateral border, laterally you have got a muscle called as sartorius. And medially you have got a muscle, this is called as adductor longus. Where is this? Medially. Okay, and this is the base, adductor. Thank you, Sean Murphy, thank you so much. This is the medial border. Okay, but in the exam they will ask you, they will not just ask you lateral border kaun sa hai, medial border kaun sa hai. No, they will ask you which border of sartorius is the lateral border. Okay, so what I'm trying to explain you is, just focus on whatever I'm telling. See, this line which I'm drawing right now is your inguinal, is your femoral triangle. See, this is your femoral triangle. Don't think this part is your femoral triangle. Okay, so this part is your femoral triangle. In this, now you will tell me, thank you so much, Face. Now in this you will tell me, laterally what do we have, guys? Laterally there is medial border of sartorius, yes or no? Laterally there is medial border of sartorius, yes or no? Uske baad medially what do we have? Now you will tell me, medially do we have medial border of adductor longus or lateral border of adductor longus? Exactly, look at this blue line which I have drawn and tell me. No, it is not the lateral border, guys. It is again the medial border. See, this border is the medial border. So that's what I have been telling you, that this is not femoral triangle. If this is a femoral triangle, then this is the lateral border of adductor longus. But outside the muscle it is there. Outside the muscle it is there. So again you have to write it as a medial border of adductor longus. Okay. So just look at this line. Okay. This is the lateral border and this blue one is the medial border. So it is located in the medial border of adductor longus. Okay. So Rini, I hope you understood. Second important thing is, superiorly we have got inguinal ligament. Ye to easy hai na? Inguinal ligament. Right. Now let us see what are the structures that are forming the floor of the femoral triangle. Ye dekho. So don't confuse with this picture. Very, very, very easy. Just remember this. Right. So this black color muscle which I'm drawing here, है ना? This black color muscle which I'm drawing here, this is your sartorius. All of you know that. So after the sartorius, see this muscle which I'm drawing again, shading again, this one is your adductor longus. But inside, do you find three muscles over here? 1, 2 and 3. Yes or no? You have got three muscles. So these three muscles form the floor of femoral triangle. So 1, 2, 3. So iliacus. This is formed by the iliacus. Next, psoas major as well as pectineus. So how do you remember the floor? Floor is formed by flip. F-L-I-P-P, flip. F stands for floor, Li stands for iliacus, PP stands for psoas major as well as pectineus. Okay, these form the floor of the inguinal ligament. Femoral triangle. I'm sorry, femoral triangle. So let us look at the contents. Yeah, Osama has given another important mnemonic, IPS. Right, very good, Osama. Thank you so much. So here if you see in the contents, guys, there are three important things called navy. N-A-V-Y. All of you know navy. What is N here? N here is standing for a nerve called as femoral nerve. This is femoral nerve. Femoral nerve के बाद क्या होगा? This one is called as femoral artery. This is called as femoral artery. And finally, this one over here is called as femoral vein. So NAV, from lateral to medial, navy, NAV. What is why, I will tell you in a minute. NAV. Okay, so these are the contents of femoral triangle. If we go little bit deep here, this femoral artery as well as femoral vein, both of them are enclosed in a sheath. ये देखो, both of them are enclosed in a sheath, and this sheath you call it as femoral sheath. Femoral sheath. This sheath you call it as femoral sheath. What I will do now is that I will take this femoral sheath and put it outside. Okay, ये देखो, this is the femoral sheath here. This is the femoral sheath which I have kept outside. Outside the femoral sheath, lateral to the femoral sheath, what is the thing that is present? Femoral nerve. See, this was the nerve that is present, है ना? Femoral nerve. Okay, and if you divide the femoral sheath can be divided into three compartments. Okay, what are these three compartments? One is called as, this is called as the lateral compartment, this is called as the intermediate compartment, and this is called as the medial compartment. Okay, in the lateral compartment you have got an artery, and this artery is your femoral artery. In the intermediate compartment, you have got a vein, and this vein is called as the femoral vein. And in the medial compartment, what do we have? In the medial compartment, we have got the lymphatic system. So there are lymph nodes in the medial compartment. All of you know these lymph nodes. These are called as lymph nodes of Cloquet, okay, or Rosenmuller. Okay, so these lymph nodes, are called as lymph nodes of Rosenmuller or lymph nodes of Cloquet. Lymph nodes of Cloquet or lymph nodes of Rosenmuller. They are located in the medial most compartment, right? In the medial compartment. Now, is there anything that you need to add here? Yes, definitely is. What is the thing is that here we have got a nerve. This nerve is called as genitofemoral nerve. Genitofemoral nerve. This genitofemoral nerve will divide into two branches. One is called as a genital branch. Another one is called as a femoral branch. Not femoral nerve. This is femoral branch. Okay? This is femoral branch. And this femoral branch is coming all the way, entering into your femoral, near to the femoral artery in the lateral compartment. So if I ask you right now, what are the contents from lateral to medial? What will you tell, guys? Tell me, put down in the comment section, what are the contents from lateral to medial? First content is femoral nerve. After that, we have got femoral branch of genitofemoral nerve. After that, we have got femoral artery. Uske baad we have got femoral vein. Then we have got, innermost we have got lymph nodes of Cloquet. We have got the lymph nodes of Cloquet. So these are the structures that are located innermost or medialmost. Clear, all of you? Everyone is clear with this, guys? Everyone? Right? So these are maximum questions that can be asked for you in your exam. Okay? So regarding the femoral triangle. Okay? After the femoral triangle, the second topic we shall be touching is the next important topic, that is adductor canal or Hunter's canal. It is also called as subsartorial canal. So what is this adductor canal and all? We shall look here now. So all of you just pay attention. This is the femoral artery which is coming down. It is entering into your femoral triangle. And once this femoral artery enters here, you see an opening there, right? You see an opening there. So this opening is also on the posterior side. So from this opening, this artery is coming out. This artery is your femoral artery. Okay. So it means from the anterior side to the posterior side, through that opening, one artery, the femoral artery is passing. So this opening is this one. See, artery is coming like this. It is passing through this opening and it is coming down like this. So this canal over here is called as your adductor canal. Adductor canal. Okay. And this opening on the back is called as your adductor hiatus. Adductor hiatus. Okay. This is called as your adductor hiatus. If I make a transverse section like this and look, how does it look? Center में क्या होगा? In the center, you definitely have got femur. ये देखो, this is femur. Surrounding this muscle over here is called as your vastus medialis. Vastus medialis. Okay. And here you have got this muscle called adductor longus. Okay. And this muscle is called as adductor magnus. Adductor magnus. And what is this muscle which is located anterior side of your thigh? That is your sartorius. That is your sartorius. So all of you just rotate the picture in this way. So if you look here, this is the anterior and this is the posterior. This is the medial and this is the lateral. Okay, so how we shall be talking this is, we shall be talking like this, posterior medially. Okay, posterior medially matlab ye dekho, this side. And anterolaterally means this side. Focus on this side. Posteromedially, anterolaterally. Okay. So, posteromedially, what are the structures you have? Posteromedially, now you tell me, what are the structures I have posteromedially? See, this is the posterior side. This is the medial side. So, from here all the way till here is the posteromedially. Adductor longus I have got, adductor magnus I have got, right? So, I will write it as adductor longus on the top. So, adductor longus superiorly and inferiorly I have got adductor magnus. Adductor magnus. Okay? So, this is posteromedially. After posteromedially, you have got anterolaterally. Anterior to lateral. It means this part. Right? This part. This entire part is anterolaterally. What do you have anterolaterally? We have got only one muscle perfectly fitting into that anterolateral position. That is called as your vastus medialis. Okay, that is called as your vastus medialis. And on the roof, okay, on the roof, what do you have? You have got this plexus. You see, this plexus is called as subsartorial plexus. Why are you calling it as subsartorial? Because this plexus is present below the sartorius muscle. Subsartorial plexus. Okay. Even if I draw a fascia like this, this will become subsartorial fascia, right? So these are the structures that are located on the roof. So subsartorial plexus and subsartorial fascia. So these are the structures that are located on the roof. Okay. And again, everywhere you go, this question is all the time getting repeated, that what are the contents here? Okay. So there are three contents here. So ye dekho, this is one vein. Okay. This is an artery and this is a nerve. Okay. So this vein is called as femoral vein. This artery is called as femoral artery and this nerve is called as Cephenius nerve. Cephenius nerve, right? So these three comprise the contents here. These three comprise the contents. So these three comprise the contents here. So all of you understood, guys? Contents, the same things. So you just write it down on your own. Right? So, Satya Mishra. So, see, any rapid revision, one thing you have to know, any rapid revision is not enough. Okay? Any rapid revision is not enough. So, the reason of rapid revision is just to brush up your knowledge on the most important topics. You know? So, I have taken 5-6 hours of your time. Is 5-6 hours mein bakwas topics discuss nahi kar sakte. You have to discuss only important topics which will come into your exam. So only these are the important topics? No, there are many more important topics which you have to discuss. So in this less time, as many topics as I could, I have discussed it. And I have already told you from today onwards, right, till the end of your exam, right, just 5-6 days before your exam, continuously I will put in live sessions. And in live sessions, एक live session में ऐसे होगा कि images of upper limb, एक live session में images of abdomen, lower limb, ठीक है, head and neck images. और एक लाइव सेशन में होगा कैडावरिक इमेजेस, एक लाइव सेशन में ट्रायंगल्स, है ना, एक लाइव सेशन में सिंड्रोम्स. सो लाइक दिस आई विल कवर ऑल, आई विल ट्राई टू कवर एवरीथिंग इन डिटेलली and make you perfect with the anatomy there. Okay, so that would be more than enough. Okay, don't worry, just trust me, that would be more than enough. So guys, one thing I want to ask you, did you like the session? Yeah, was the session worthy for you? You have spent 4 5 hours of time, yes or no? Right, for everyone it is good. Thank you, Satya Mishra. Thank you so much, Osama Sheikh. Thank you always. Right, everyone, the remaining students, all of you like the session, guys. Very good, Rini Atkinson. Very good. I hope my all my explanations helped you. Aman, thank you so much. Thank you so much, Aman. And the remaining students, Sean Murphy, you understood? Was it worthy for you? Yeah. Felicia Verghese, Rusty, Jonas, all of you are clear with the session, guys? Yeah, all of you are clear, right? So the next session, thank you so much, SVN Prasad. Thank you so much. SNV Prasad, I'm sorry. So the next session will be by Dr. Ramya Gubba. So she will be teaching gynecology, right? So I think her session is on 16th, right? So 16th at 6 o'clock in the evening. So please do attend her session also. So many important points of gynecology will be discussed there. It will be Fox Bay. Agwu Ezine, very good. I haven't changed my look. I had to change it, you know. I don't want to remove all the beard and all, but there was a mistake happened during the trimming and also I had to remove it out completely. But anyways, guys, so thank you so much for trusting and believing in me, and you're here for long time, and most of you were supporting me. Most of you were supporting me from long ago itself when I was posting the videos, live sessions and all. Most of you here in the comment chat, most of you were there from my beginning of my career and all. So thank you so much and all the best. Anytime, any help, I'm ready regarding the subject and all. I will always be there. So goodbye, guys. Love you all and take care.